The thing about the trauma model that I like so much, that in working with him over 25 years and working with so many different people with so many different diagnoses, so we're sitting on a unit where we have someone that has PTSD, someone else is there for major depression, someone else is there for generalized anxiety, someone else is there for dissociative disorder, someone else is there for alcoholism, eating disorders, drug addiction. So we had every different diagnosis you can think of. And people that came into the program would have 6, 7, 8 active diagnoses when they walked in the door. So we had to create a model that was applicable to all these different diagnoses. And it actually happened accidentally as we grew from the dissociative disorder unit, where we were just treating people that had multiple personality disorder. And when you treat someone with multiple personality disorder, what you start becoming aware of is very clear ego states or alters, which is what they're also called when you're talking about MPD, or now what's called DID, dissociative identity disorder. So as you start learning the mechanics of the inner world through alters and understanding the system of the internal world, you start realizing, wow, this is really applicable to anybody with any diagnosis. They happen to have alters that can present in very concrete, tangible, differing ways, differing viewpoints, perspectives, but that same dynamic or that same conflict is going on with a man that's an alcoholic that knows he should stop drinking, but he can't stop the behavior. There's two different parts of self that are at war with one another. So starting out learning about alter egos, or not alter egos, I'm sorry, alters in different ego states. When you start to recognize that world, you can see how you can utilize this in every type of therapy that you use with every type of diagnosis. So I compared this model to the Vegematic of the 70s, where it slices, it dices, it chops, it shreds, it grades. You can use it for anything. Even people have said to me, well, Melissa, what about someone that has had a closed head injury? Or what if someone has struggles with some mild forms of retardation, or they have some developmental milestones? The model's still applicable, because it doesn't matter who you are or what you have going on, where you're at intellectually. You still have to learn how to manage your emotions to the best of your capability, wherever you are, whoever you are, however you're struggling. So when we had people that had closed head injuries, or if I have children, I have kids that come into my private practice, I can scale this model down and help them still understand the material, because the bottom line, it's all about teaching them how to manage overwhelming emotions in a better way than what they've been doing. So all of us have to learn healthier ways to manage feelings, regardless of our intellectual abilities, regardless of our age to a degree, or our diagnosis. So it's applicable for everyone. So what we're going to go over today will fit regardless of what the diagnosis is. It will always fit, because every person's got to learn a way to have better coping skills and manage overwhelming feelings to the best of their ability. What also has changed over the years, as we've been going out and speaking, what we've learned over the last 20 years or so, is the definition of trauma, that we've really broadened the definition of trauma. And I think most of you here see this because we've been over it before, but for the benefits of the recording, we'll go through it again. Used to, we talked about trauma being sexual abuse or physical abuse, and those were the two main things that we talked about when we talked about people being abused. Then we started looking at emotional abuse and recognizing the damaging effects of emotional abuse. And I would have people come up to me in the program when they were getting ready to go a lot of times, and they'll say, you know what, I really wasn't sexually abused. And I don't want you to think less of me because I said that I was. I just didn't know how else to convey the depth of pain that I went through growing up in my home. I had a parent that was never there. I mean, I never had anybody. All these people are talking about the parents they had and how they abused them and they mistreated them. I never had a parent available at all. It was such a lonely place, and I didn't feel like people would understand the depths of my pain if I talked about what I didn't have versus what they did have, even though what they had was terrible. And what we've actually learned is that when you get the people that come in and they've had horrible, horrible sexual abuse, and they tell these stories of incest starting from ages 4 to 17, and you hear story after story, and you think to yourself, golly, that's horrific, and the amount of grief that the person expresses and deals with and processes while they're in groups during their stay, and they get in touch with all the pain of what they've been through and what they've experienced, you think to yourself, the person has gotten to the deepest level of pain that they could possibly experience. They've grieved that traumatic experience. They've done their grief work. But what we actually started finding out was after the person grieved the painful experiences that happened to them, there was a deeper, even deeper level of grief that they would get in touch with when they had to start looking at what wasn't there. So we tend to think, oh my goodness, listen to these horrible stories, and we get caught up in the details of the context of the storyline of what happened, the actual abuse itself. And while that's painful and deserves and warrants time to be expressed and processed and dealt with and invented, we can't forget or underestimate that there's an even deeper pain beneath that is attached to what they did not have. And Colin will say, grieving the loss of the parent you did not have. I wished I had a daddy that had been safe. I wished I had a mom that could have loved me, told me she loved me, wrapped me in her arms. I wished I had a dad I could be safe with and could sit in his lap and nothing bad would happen. There is a very deep, deep pain that goes even deeper than the context of the traumas that we hear so much about. And so it helps us to get off of the focus and the horror of the storyline that the patient presents with. Not that we shouldn't do that, not that we shouldn't help them have a place to express that, but we have to be aware and help guide and structure our treatment so that there's a continuation from that place to the next phase, which is going to be looking at what they did not have. And that is so often missed. And I learned it from clients who felt like they had to say they were sexually abused or physically abused to explain the depths of pain that they experienced by neglect. So we've added sexual abuse, physical abuse, emotional abuse, which includes verbal abuse, shaming. I mean, most of us know what emotional abuse is, but emotional neglect is also on there. And I've talked about how I've had parents come into my private practice and they'll have teenage kids and they'll say, you know, I don't get what her problem is. I mean, why is she depressed? She has the best car at that school. She has the best wardrobe money could buy. We waited in line for 5 years to get the nanny that she has. We have this wonderful house that we live in. Both parents are working all the time to be able to provide to their child the material things that they think brings happiness, but what the child does not have is just actual contact with their parent and the time and energy of relationship with their parent. And we are so focused in our society as a whole, in our culture as a whole, at having things that we forget about what it's like to just be present with someone and the value of that, especially for developing minds and bodies that in our children. Because where children learn how to deal with their feelings comes directly from their primary caregivers who are involved in their life the most. It's going to be either the parents. I've had people say to me, you know, man, neither one of my parents were there for me for various reasons. But I had a 3rd grade teacher that loved me and told me that she loved me. And I felt special from her. And sometimes just having one connection like that for children can do so much in the development of a child's psyche and their self-esteem. So when you're thinking about trauma, if you'll broaden the definition, and it's not just physical abuse, sexual abuse, emotional neglect is also there. And some people would say, well, now, I don't know if I would call this traumatic, but if you had parents that did not know how to deal with their own feelings, if they had parents that were alcoholics or had their parents struggled with mental illness or weren't available, if they don't have it from their parents, they don't know how to give it to their own children. So if you didn't have parents that knew how to help you with your own feelings or were able to be available to you or teach you how to deal with your feelings, is that traumatic for a child? Well, some people will say, well, I consider that traumatic, and other people say, well, whether we consider it traumatic or not, it sure sets that kid up to not know how to deal with life and life experiences as life unfolds, because life is going to be up and down. So either they had a history of physical, sexual, emotional abuse, emotional neglect, and or they had parents or caregivers that did not know how to deal with their feelings, therefore could not teach their children healthy ways of dealing with their feelings. I haven't met a client once that's ever come into my office, that's ever been in any of the 3 facilities that we've worked at over the last 20 years. I've never had anyone that doesn't fit that criteria. Because no one comes to our offices because they're having difficulty feeling too happy. They come to our offices because there's painful feelings they don't know how to process, they don't know how to deal with, and they get caught in them. And they wind up getting stuck in behaviors that they can't control, or even thought processes that they can't control. So when you broaden the definition of trauma, and you look at what is trauma, we have physical abuse, sexual abuse, violence and assault, emotional abuse, verbal, accidents, spiritual abuse. What would you say is spiritual abuse?
forcing the family's beliefs of whatever the Christianity is. You have to go to church meetings, you have to go Sunday, we're going to go this Saturday, you have to do this, you have to do that.
So feeling forced in the family to go down a certain path, to have a certain spiritual view or religious view. Being abused also by spiritual leaders, whether it's your minister or your choir director, and there's a lot of people that are reporting, as we know, more and more spiritual abuse in that way, where the person that is the leader of their spiritual life in one form or another is also abusing them. But yes, spiritual abuse is also being forced, and what one person would call abuse, another person may not. Obviously, bullying, rape, death, violence in the workplace, childhood neglect of physical needs, abandonment, childhood neglect of emotional needs, multiple life stressors, infidelity, burglary, parents who had poor or dysfunctional coping skills, that's what we just talked about, car wrecks, abortion, domestic violence, divorce or a breakup, suicide of a loved one, loss of job, medical diagnosis, chronic illness, loss of functioning. Now that's interesting too, because I had a young lady that came into our program years ago, and she had a diagnosis of borderline personality disorder, which means there's probably some trauma there. We dug and dug and dug, and we really couldn't find anything that was obvious that was traumatic from her childhood with her in regard to her parents or her upbringing. However, she was born with a cleft palate. And I cannot, to this day, remember if it was 24 surgeries before she was 36 months old or 36 surgeries but before she was 24 months old, but would that be considered traumatic for a child? Absolutely. So quite often, it's events that can happen not necessarily in the home. It doesn't have to be in your home, although it can be in your home. But there's a lot of events that can affect us that we have no control over that are still traumatic. So for her, being born with a cleft palate, that was a very traumatic experience that she went through. Infertility, miscarriage, if you've ever worked with women that struggle with infertility, very traumatic. Natural disasters, war, combat, political violence, chaotic, dysfunctional environments, financial difficulties, birth defects, high-stress job, pregnancy and childbirth, witnessing something traumatic, psychiatric issues and hospitalization. Can hospitalization in and of itself be traumatic? Oh, absolutely. I mean, that's a hard thing to have to go through, to go into a psychiatric hospital, to even going into a rehab facility. Can that be traumatic for people? Can it be traumatic if a loved one of yours is going into a hospital or is going into a treatment center? It absolutely can be. Chronic relapse and consequences of the relapse. That's what we're talking about with the people that are struggling with maintaining sobriety. Addiction and related consequences, learning disabilities. So when you look at this, has everybody in this room experienced at least one of these? Does that not apply to all of us on one level or another? And if you take it one step further, we talk about everyone will experiencing something traumatic in their lifetime. It's how you deal with it that matters. And how you deal with it has come from what you were taught, what you were shown, how your parents dealt with their feelings to teach you how to deal with yours. And I joke a lot of times with the clients in the hospitals over the years. I'd say, you can't be upset with yourself for not knowing how to fly a Learjet. You've never been shown how to fly a Learjet. Now, in 24 years, I actually did have someone raise their hand and said, I actually know how to fly a Learjet. I said, okay, bad example. I'll come up with another one. But you can't beat yourself up for something you don't know. And we go to school to learn more and to develop our intellect more and to get an education. You can't manage what you don't understand or what you don't know. So I told the clients at the hospital, I said, we really could just call this ESU, Emotional State University, because what you're here to do is to learn how to manage your feelings. This is a place to actually learn what they are and to start practicing them to try to make up for what you did not learn when you were a child growing up. And that's really, in a nutshell, that is the premise of every diagnosis that we treat. It doesn't matter what vehicle they use to drive away from the emotions. It doesn't matter if the vehicle is drugs and alcohol, sex, gambling, pornography, eating disorders, depression, anxiety, and we'll talk more about that later. All of those are just simply vehicles to get away from a root pain of something else. So we have to find the underlying pain. Because if you don't deal with the tap root of pain, what will happen is you'll see a person go from one addiction to the next, to the next. Then they'll add on a mental health issue. Then they'll add on another mental health diagnosis. Then they might add on high blood pressure, irritable bowel. You'll just see this rotation in this circular pattern of mind, body, back and forth, back and forth. And the symptoms can change and the doctors can change, but the taproot is the same. Now, I've had someone also talk about, and I started reading on this more, some people kind of argue about, well, I don't know if it's traumatic. Traumatic shouldn't be the right word. And they actually, there's what's called the adversive childhood, it's ACE, Adversive Childhood Experiences Scale. And I thought that's pretty accurate. That's a little bit more palpable. Some people don't like the word traumatic. Some people kind of steer away from that word. Some people don't recognize it as traumatic. I've had people that I've worked with over the years, and I had a lady that said to me, she said now, she didn't report any sexual abuse, and then as we started working in therapy and we started talking about things, it came out that her first sexual partner was her father. And I said, but I thought you said you weren't ever sexually abused. She said, oh, I wasn't. He just wanted to make sure the first person that I was ever with really, really loved me. So there can be a lot of twisting. I mean, and people don't always recognize that it's traumatic, or they're too embarrassed to report that it was abuse, or they're too embarrassed to report there was sexual abuse. So I think adversive childhood experiences, that is a little bit easier to swallow for some folks. Some people can recognize that they have had painful experiences as a child. And when you looked at that list of trauma that I had, and you look at your whole lifetime, we've all had adversive experiences in our life. And what does matter is how you deal with it. Because you can have 2 women or 2 men that go to combat, or 2 women that get assaulted. And both of the women, let's start over here, both of the women that have been assaulted have been raped. One may need to go into an inpatient facility for treatment. The other one may not. Not everybody that experiences trauma or something traumatic or adversive, not every single person that has traumatic experiences necessitate going into an inpatient facility or get caught in a cycle of drinking for the next 5 years. So what is the difference between someone who needs needs to come into a treatment facility versus someone who may not need any help at all on an outpatient basis? What is the difference in those people?
How they process or deal with what happened.
For sure, how they've processed and feel it.
I was going to say personality.
Their personality. So a lot of times people say, well, this is genetic, right? This is all genetic, and you have to be careful with this because it's not that. I'm not going to say it's not genetic or it's never genetic. That makes no sense. But in our culture, we tend to think of things as environmental and genetic. And when you're actually in the field and you're in the trenches with people and you start learning more about them and understanding and figuring out the things that have happened that maybe have shaped some of these behaviors, it's not that genes aren't there, but in actuality, it's genes, genetic, and environment. It's the total opposite. Because if that's not the truth, therapy wouldn't work. It's just the person's got bad genes. I mean, best we can do is hope they take their pills, take their meds, because they're just kind of a genetic mess up for the rest of their lives. Treatment works because it is environment, and it's the effects of environment, and this is the stuff we can deal with. So I'm not going to say that genes don't do something or play a piece of this, because they do. Genes have a lot to do with how sensitive we are. Genes have a lot to do with the way we process things, the way we experience things. It's not that genes don't come into play, but we've done a disservice by creating the belief that this is genes and this is environment. And one thing is, we've put a lot more money into trying to find these genes, and we're not finding them. Did Colin talk about this at all? We're not finding them. The more we learn about addictions and we start trying to find that specific gene, the more we're finding out the genome's getting bigger and bigger and bigger. We're not getting better and better at honing in on this gene. It's getting bigger and bigger and bigger. And what we're learning, a lot of times people will say, genes are the bullet in the gun, and environment is what caused the trigger to be pulled. So you can have genetic tendencies that don't have to be expressed. But if your environment is damaging enough, then it can be expressed. And that's the same for people who say that when they have a genetic predisposition for diabetes, And two people can have a genetic predisposition for diabetes, and one got diabetes and the other doesn't. Do you think environment has something to do with that? Well, yeah, that's what they're showing over and over again. So it's important for us to not get too caught up in genes. It's worth mentioning, it's worth looking into, but it's kind of backwards. Can anybody guess why we have gone down a road where it's genes and environment? Any guesses why our country and our culture is so heavily invested, there's a key word there, in making everything genetic?
It's like a finite answer.
Do what?
It's like a finite answer.
And you can get a specific answer, and what is the answer? Pharmacology. Now, I didn't say that. Yeah. Is there an investment, is there a financial payoff to believing or us being taught that it's all environment?
No, because
No. But if it's all genetic, yes, because then there's pills for that. There's pills for that. Now, I have to be very careful because when I do this lecture to large audiences, I can get dinged or get in trouble because they feel like I'm poo-pooing the pharmaceuticals and the industry, the medications. It is not that. Not at all. I'm just saying, I'm just trying to shift it from here to here. There are some people, if they don't take their meds, they can't get out of their bed to get in their car to make it to my office to be able to do therapy with them because they're so depressed. Or they have so much anxiety, they can't even focus on what I'm saying to be able to benefit from it. So do people need to take meds? Yes, people need to take meds. Do they need to take meds as much and as often as we do? No. And have we learned that as people get stronger about being able to manage their feelings better? Here's what we've noticed. There's a trend. As people get stronger and emotionally more capable, as they get emotionally more mature, as their emotional muscles get stronger, we'll notice they'll come in and they'll say, you know, the weirdest thing, I've been taking this medication for the last 10 years with my doctor and I can't get out of bed anymore. I'm so tired, I can't even get up. So they'll go to their doctor and they'll say, well, that's kind of strange. I don't know what could possibly be causing this. It couldn't be your therapy. Let's cut you back a little bit. So they cut them back a little bit. You know, what's better, but I'm still tired. And what we'll notice is as people get more able to manage their own chemistry, because when you're in a healthy place emotionally, does that affect us chemically? 100%. And so if we're in a different place chemically and you're managing your emotions in a healthier way, which means you're managing yourself chemically in a healthier way, they need less and less of the artificial chemicals. They don't need as much of the artificial chemicals anymore because they're able to manage themselves chemically on their own. And so we'll see people's medication just titrate down, less, until they don't need it anymore. Now that doesn't mean that you're a treatment failure if you still have to take some medication. But if you can reduce your medication, I mean, if you can reduce your pharmaceutical bill 75%, it's worth it, right? Not every single person that is diabetic can manage their diabetes through their diet. But does that give that person permission? It's like, well, I'm going to be on insulin, doesn't matter. I might as well eat Snicker bars for breakfast and Twinkies for lunch. No, you still have to do everything you can do, but if you have to have a little bit of insulin to make up for what you don't naturally have. So I want people to work from the least amount that they are required, that they have to have, but for them to do the work themselves. But we've bought into that it's mostly genetics because there's a payoff for that. And that doesn't mean there's not a place for pharmacology. And that's another lecture from Colin. That will be disc number 45, CD number 45. Okay, so let's look at, we've talked about this a little bit. Trauma is a developmental obstacle in normal human development. So what all do I mean by that? Normal human development, as we grow and as we start having a sense of who we are, we've learned if there's a traumatic event that happens in a child's life, if it happens enough and they don't have the resources to process it, they will get somewhat stunted on an emotional level, developmentally. Not physically, not intellectually, but emotionally. So I have adults that are this big, but they are emotionally operating from a mindset of about this big. So you'll see that in people. You'll hear that in the language, the way they describe their feelings, the way they talk, they describe their thoughts. You'll see that there's kind of been this emotional stunting. So we see people that are somewhat developmentally stunted on an emotional level, or they wouldn't be coming to us to begin with. When you realize it's a developmental obstacle, it also helps you to realize that just talking to someone isn't going to cut it. Developmental means it takes experience. You have to actually practice it. You have to put it into practice. So just telling someone, it's important to be able to explain it to them, but then you have to practice. And that's why the program here is set up the way that it is, because we have cognitive therapy. We have a lot of educational groups. We're up there writing and lecturing, and I teach this stuff in the education groups here just like I would at workshops, same information. But half of our program, we set it up where it's experiential. That's why we have art therapy, equine therapy, psychodrama. We have body image groups, yoga. We have a lot of things to help people get connected to their bodies and actually start practicing feeling the feelings. Because just talking about it just appeals to this. Well, I've already said people coming here, there's not a problem with this. The problem is here, dealing with the emotional piece of it. So we can educate them, but we're not doing them any favors if we don't teach them to how to actually manage the emotions, because emotions are energy, and the energy is in our bodies. That's where we experience it, is in our bodies. And if they don't learn how to manage those feelings in their bodies, we're not doing them any favors. They can have all the information here in the world they want, but if they don't know how to touch into this or get this and this to connect, if they can't bring mind and body together, when they leave and they get all emotionally worked up, this isn't going to be available to them. And we'll talk about that a little bit later too, after the break, with the fight or flight response and how that shuts down your head. So they talked to, after the Oklahoma City bombing, if any of us had been there, it wouldn't surprise anybody if we had PTSD after that experience, right? That would be a horribly traumatic thing to go through. Wouldn't surprise any of us. After the Oklahoma City bombing, they noticed a year later, there were still people that had active PTSD symptoms. They were still struggling with intrusive thoughts, intrusive images, intrusive feelings, to the point that they couldn't function. 2 years later, they noticed that. 3 years later, so they took a survey. And they started talking to these folks. And they said, I bet you I know what it is. I bet these people that have gone from acute PTSD into chronic PTSD, I bet I know what it is. I bet that these are the folks that were actually there when it happened. So they go talk to all these folks. And guess what? They weren't all there. Some of them were, some of them weren't. They said, oh, I know what it must be. It must be either they were there personally or they had a loved one they were close to that died there. So they continued the survey, and guess what? They weren't all there. There were people that had active PTSD after the Oklahoma City bombing that were not there, didn't even live in Oklahoma, didn't have any relatives in Oklahoma, didn't have anybody that was hurt in it. Why would someone struggle with chronic post-traumatic stress disorder symptoms that was not even there or did not lose someone personally, wasn't affected by that event?
Does it trigger something that they did have?
What they found is that they had traumatic childhoods.
Yeah, they had triggered something.
Yes, so it triggered something from their own past. So if you're walking around in this world and you've got a lot of pain, and we've got a young man now who's 21 years old, his body is 21 years old, but in what he has been through, he's about 110. He's had more traumatic experiences happen to him. So he's already walking around with all this stuff that he's had to push down because he didn't have parents that taught him how to deal with this pain. So everything's been pushed down, and he's got everything down. It's capped off, and it's right here. So when something else happens to them, let's start with just the normal experience that he does go through. He's going to be drowning in it versus the person, as Colin says, had the average neurotic childhood, where you have a lot of uncomfortable, painful things maybe here, and when something traumatic happens in your adult life, it may take you here, but you're not drowning in it. So for the people that weren't even anywhere around and didn't even know anybody out there, it triggered feelings from the past where they did have a sense of helplessness. Same thing after 9/11. We got calls from all over the world. And these were people talking to us. When you watch those people go to the ledges of those buildings and jump, it made everybody sick to their stomachs, right? I mean, it affected everybody. And it was painful and difficult. But people who got chronic PTSD from that experience were people that had had times in their life, and they were already up to here, where they felt so helpless. And then when that event happened, it just took them over the top. They were drowning in it because it opened up all this emotion, and they didn't have much room left for that kind of pain to be added on top. So when someone comes into my private practice, I know right off of the bat that there's either a thought pattern or behavior that they're not in control of, or they wouldn't be in there. They already have something more than likely. After 4, 5, 6 different sessions, if we can't get something resolved that's been painful that they're trying to deal with, it tells me there's probably some foundational issues here. There's probably some traumatic experience that they've endured, and that's why we can't just resolve it. For example, I had a colleague, he's a therapist, a good friend of mine up in Chicago. And this is actually his story, and it's such a perfect example. I've used it ever since I heard it. Even if we're talking about childhood trauma, how that raises the bar, and that person may have more stuff in there you're going to have to sort through, an adult experience, like we're talking about, a single adult experience, traumatic event, if it opens up all this stuff, you still need to look and see what's in the foundation. So for his example, now this is a fairly healthy man. He's your average neurotic counselor. He's a fairly healthy man, and he said, I work with trauma survivors. He does hypnosis. He's been working with trauma survivors for years. And he said, I was in a car wreck. And he said he was driving to work, and he had a little sports car, and somebody ran a stop sign and smashed into his car, and he was thrown to the floorboard. And he said he can remember laying in the floorboard, and he couldn't breathe. And the young lady that was driving the other car got out and ran over and saw him in the car in the floorboard and started screaming and crying because she thought he was dead. He was a mess. And he said, I have little snippets of memory. He said, I remember the ambulance came and they got me out. And he said, I couldn't breathe. And he said, I can remember when they had me on the gurney and they were taking me onto the ambulance. And he had said, I told them, please take my phone, dial 555-4392 and tell my patient I'm going to be a little bit late for session. So they put him on the ambulance and they take him to the hospital, and he had a punctured lung and he couldn't breathe, and he was very banged up. And there was actually a point in time there, it was a little touch and go. They were not sure if he was going to be able to pull through this. Well, after several weeks of being in the hospital, and then when he was released, he said he went home and he went back to work, and he said, I started thinking to myself, and he said, I kind of started patting myself on the back thinking, man, I've really got it pretty together. I figured I'd be kind of traumatized from that experience, but I'm dealing with this very, very well. And he said as soon as he started thinking that, he started noticing. He started having anxiety just walking out to his car. He started having anxiety going to the office. He couldn't sleep at night. He started getting depressed because he couldn't control his anxiety. Then he lost his appetite. He said, if I was someone that was drinking, if I was someone who drank, I could very easily start drinking just to try to squelch the anxiety so I could get in the car and get to work. So he started seeing all these symptoms and diagnoses just piling up on top of it. And he could have gone to one person, they said, oh, we need to deal with your depression. If he'd been drinking, oh, we need to deal with the drinking. If his anxiety, oh, we need to deal with the anxiety. Oh, we need to deal with the PTSD. All these different people, your sleep disorder, the fact that you're not eating right, they would have started plucking out all these different diagnoses. And I remember one time I asked Colin when I was an intern years ago, I said to him, how do you know which one is the primary diagnosis? He said, oh, that's easy. What's the last workshop you attended? It's like, oh, okay, that's how they do it. He said it's so hard to tell from. There's so many different diagnoses, and just depending on where someone has their expertise is what they'll pluck out. A lot of times is the most important. Now, obviously, you can't do any kind of therapy with someone who's stoned. So, do you have to get cleared up? Some of these things are a no-brainer. If someone's not eating, you have to have food. But in the big picture, when you have a traumatic event and you start getting this variety of diagnoses piling up, you can start medicating and give medicine for this and go to this treatment center for that and this facility for this and this medication for that. And a lot of times we only treat this, but we don't treat that, or we just treat this and we don't treat that. Do your work here and then we'll transfer you there. So there's all the, instead of just saying, whoa, this is what caused it. It's not that we don't want to address these things, but here's where we need to go. So he said he realized he had to do something. He said, I can remember the day it happened. He said, I was watching children's ballroom dancing. And he said, little Timmy got second place, and I thought he should have gotten first. And he said, I just burst into tears. And my wife said, you have got to go talk to somebody. So he said he knew at that time there was too much, and he said he went into, I think he had 5 outpatient sessions with a counselor. And he said what he had to get in touch with was the helplessness that he felt when he was in the floorboard of that car. And he said it was helplessness in so many different forms. He said it was helpless in the sense that I couldn't even breathe. I was helpless in my own body. Helplessness is one of these tap roots that we're going to see. When there's a feeling of helplessness, nobody likes that, and that's a very scary place. And so he had to get in touch with the helplessness, and he said, since I had a relatively stable childhood, I could identify that feeling. I talked with her. I cried. I grieved. I got it out. He said, I had to deal with the helplessness of not being able to help the girl that came to the car that was crying and screaming that she thought she had killed me. So there's all these different feelings. And once he started processing the sadness and the fear and the helplessness, in particular the helplessness, he said each time he talked about that with the counselor, his symptoms would abate a little more and a little more and a little more. Now that's someone who has the resources and knew how to deal with the feelings when they came up and could identify them even. Take someone that has childhood trauma up to here and they've never had anyone to talk with them or deal with their feelings. They can't. I have people with tears streaming down their face and I'll say, what are you feeling? They'll say, I don't know. So we're dealing with people that don't even know how to identify their feelings. And we don't really live in a society that encourages people to identify with their feelings. And we're not taught this in school. So if you're not taught it by your family, there's really no place to learn. I do the same lecture for the school districts. They'll have kids that are self-mutilating and cutting their arms up. And so I'll go in and talk to the school counselors about how to address this and what's going on. And we went over all of this. And I said, well, we need to teach this at the school. And they said, this is very, very important. So they fought and they fought and they fought with the school board, and they finally agreed it was very important. So they gave them 30 minutes a year to be able. I said, it's a start. We'll start there. We'll start there. It's better than nothing. But so much of our culture is about a quick fix. Delayed gratification isn't even an option anymore. There's nothing to be learned from pain. I want to feel as good as I can, as quick as I can, and it's all about self. I remember in sociology in school, and it was in my sociology class, they did a national survey of the most popular magazine in the 60s. And the most popular magazine in the 60s was People. And they did the same survey in the 70s. And the most popular magazine in the 70s was Us. And then they did a survey for the 80s. Does anybody want to guess what it was in the 80s?
In the 80s?
Self. Yes. So there's a little bit of a cultural trend. And so much of it is, it's hard to even have personal responsibility for self. It's all about what they did out here that make these bad things happen to me. So we're in a very emotionally underdeveloped culture. The more industrialized, the more advanced we become, it almost seems like the more emotionally immature as a culture we become. There's nothing to be learned by going through pain. There's nothing. There's pills for everything now. Everything. I remember watching TV one time, and there was a 60 Minutes, and I thought it was a Saturday Night Live spin, but it had the clock, click, click, tick, 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 and it said, ladies, does your man cheat? Recent research has shown that he may not be able to help it. There has been a gene that we think identifies why men, and I thought it was a joke, and then I remember, but it wasn't, and the announcer wasn't a female, just so you know. And then I remember hearing about a pill for restless legs. And I remember thinking, holy cow, we are going to have a pill for everything. So we come from a society that's pumping this on us, and we're here in these programs trying to teach, you got to sit in this emotion. We're going to sit with you. We're going to help you get through it. You're not by yourself. You're not alone. Cry. It's okay. Get angry. It's okay. There's appropriate ways to feel your feelings. You've got to learn to deal with this, or you're going to continue to substitute one addiction for the next, for the next, for the next. So to go, and I would have treatment facilities call me, and they'd say, can you come out and work with us? We have a lot of clients that are acting out on the unit. And I'd get out there, and I said, where's your anger? Where do they deal with anger management? Oh, we have an anger management group. So I'd go sit down in the anger management group, and they'd all get their piece of paper, and it would say, what to do next time I get angry. Throw ice, scream in a pillow, throw rocks. And it's just a list of things they can do. Now, it's not bad to have those lists, but to sit and read that list, when someone gets angry and your physiology kicks in and you go into the fight or flight response or the stress response, your prefrontal cortex turns off. So all the stuff that you read right here is not going to be available to you. If anybody in this room's ever had test anxiety, You know that to be true. If you get yourself worked up, your prefrontal cortex turns off, and I remember sitting there thinking, I can remember where on the page it was. It's on the left-hand side. There's that picture of that girl. I can't pull it up. If you get yourself too worked up, your prefrontal cortex turns off, and you can't recall information that you know is in there. So if we have a program that just deals with education and just cognitive behavioral, it's not, in my opinion, it's not going to be effective like it needs to be, because you're only addressing the person from here up. And that's not where feelings live. And the problem is not an intellectual problem. The problem's from the neck down, where the feelings live, because it's an emotional problem. Why people come into these doors, why people struggle with addiction, why people have mental health issues, it's an emotional problem, not an intellectual problem. So what they have to learn is we still have to give handouts, and we still teach, and we still write things down, and people still take this in. But then we have groups like anger management, where the person actually, the way we do it is we have a clay board on the wall that's been painted with an oil-based paint, and we have oil-based clay. And you throw the clay at the board. And we did that, we came up with that 25 years ago, because in an inpatient facility, you can't ever leave. You can't go outside, you can't do anything. If you could skip stones, we could do that, which might be an option here. But what I need to do is when that person is throwing that clay and they're able to get that anger, and I'm seeing that, because it's energy. Feelings are pure energy. They're neither positive nor negative, but how we learn to express them can be positive or negative. I never was taught, I have two masters. I have a master's in art therapy, and I have a master's in clinical psychology. Neither one of those graduate programs ever said to me, Melissa, you're going to have to tell adults that feelings are pure energy. They're neither positive nor negative. Matter of fact, nobody ever even defined a feeling for me in any of my graduate studies, ever. We were just told, help people deal with their feelings. You want to help people get their feelings out. No one ever actually told us what a feeling was. And no one certainly told us we need to tell adults what feelings are. So in the groups that we have where people are throwing the clay at the board, there's energy in their body, and I've got to see where they've stifled it. Because if that energy was moving and flowing out, they wouldn't be drinking. They wouldn't be drugging. They wouldn't be using these things. So the energy is trapped. So when they're throwing this clay, and they're throwing the clay at the board, you can literally see in their bodies where it's stuck. And for some people, they'll throw like this, and you can see up in their back and in their shoulders. You'll see some people throw they'll bite down on their jaws. You have to look, where is it in that person's body that they're holding the anger, and help them release it. And quite often, it's just asking them to do the opposite movement. I did it, work with a gentleman a couple of days ago. And when he was throwing the clay, he was throwing it, but he was stopping it. He was stopping it right here. And he did that, and I was talking to him about it, and he just couldn't relax. He couldn't allow that energy to move out of his body. So I literally said, I'm going to touch you. And he said, okay. And I put my hand up on his shoulders, and I said, right here. I said, do you have the weight of the world on your back or what? He goes, yes, I've always felt that way. I said, right here in your back, I want you to focus on this. Can you feel my hand pushing up against you? And he said, yes. And I pushed my hand along his back. I said, this is what I want you to focus on. What color is that anger? And he said, well, I don't know. I said, well, what color would you think? He said, probably red. I said, okay, where would you experience it? He said, it was right across my back. I said, okay, what I want you to do is when you throw that clay, I want you to envision that red moving down your shoulders, down your arm, down your wrist, in your hand, and I want you to picture the red going on that board. So I didn't want him to think about anything, no judgment, nothing, just focus on the color red coming through his arm. And that's all I had to say. Touch him on the back. The next thing, he was throwing the clay, and you could just, everybody in the group, you can feel it. You can feel it. So he's throwing this clay, and he did this, and he threw, and he was talking about how he was yelling about how angry he was, and then he would just throw the clay, throw. He never got enraged, and I have to be very careful because anger work is not about rage work. Rage is not anger. They're two different things, and that's a mistake people make. It's not about just letting him spew all this rage out. He needs to stay grounded. And I have to make contact. I have to keep looking at his eyes. So I'm handing him clay as the facilitator. And as I hand him the clay, when he reaches to get it, if his hand's shaking, I will wait. And if they can't get that clay, they'll look up and make eye contact with me. And if I can see he's grounded, I give it to him, and he does it again. But if I don't pace him, he will just go with that and work himself way up into rage. Why? Because rage feels good. There's a loss of control in rage. We don't want people to lose control. So I keep him grounded in his head. I need his body and his head together. So he's throwing the clay, and afterwards he just shook himself off, and he said, he kind of jumped up and down, and he said, oh my gosh, I've never felt that much better. He said, I've never been able to let that go. That's incredible how that feels in my body. And all I had to do was touch his shoulder blades. That's all I had to do, and show him where it's stuck. And I have example after example after example after example. You hear about the same thing where you'll hear about a masseuse, and they'll say, craziest thing, this person had like a knot in their leg, and I just was pushing on that knot, and they pushed into that knot, and when they pushed into it and forced that muscle to relax, they said the person just burst into tears. We hold energy in our bodies. And for some people that sounds a little frou-frou. If you work with people and you work with energy and you do experiential, you know it to be true over and over and over and over. Same with yoga. We have people here that do yoga. I've had clients that said, one gentleman said, well, she stretched the sadness right out of me. He said, I started stretching and stretching, and I couldn't believe I just started sobbing. He said, what's that all about? There's a book actually called The Body Keeps the Score. And whatever the head tries to forget, your body won't. And we can convince ourselves of all kinds of things, but the body didn't buy it. Is there a correlation between high blood pressure, migraines, back pains? Do you think there's heart problems? Do you think there's a correlation with holding emotion in and the effects that it can have on our bodies? You bet. That's been proven over and over and over. Now, that doesn't mean we don't get things medically checked out. That doesn't mean we just say, oh, this is all about emotion. We're still going to get things medically checked out. But we've got to teach people how to find their bodies and how to get in touch with those feelings and how to actually release those feelings. And when that man looked at me to get the clay, and I looked up at his eyes, and he's still with me, he's still grounded, his head's still there. Now let's go to someone who reaches over to get that clay, and he looks up at me and he's not there. And you have to look in people's eyes. I can have people's hands trembling and they look at me and they're grounded. But you know what it looks like when someone's not grounded. And so you have to make a lot of eye contact with people in group when you're doing anger management. Really any group, but especially an expressive group, you need to try to be able to see what's going on. And in anger management, you have to be very careful because it can get very out of control very quickly. And a lot of facilities that let people beat stuff with a bataka bat or punching bag, and they don't keep their mind engaged, they're not helping them. They're just letting them learn the defense mechanism of that turned off and it made me lose my train of thought. They're just going into the defense mechanism of using their bodies and going to the hysteria of their body and letting their body just get all off the charts. They're actually triggering their own fight or flight response. And that's not grounded. We want their mind and their body to both be there. So to get lost in emotion and to overdo it is not healthy for the person. Or to be shut down and just do this arid intellectualizing and this cognitive therapy where you never really get in touch with any kind of feelings, that's not helpful either. You're just colluding with the head. You've got to get head and body working together. So for the gentleman that turns around and he's all googly-eyed when he looks up at me and he's not grounded and he wants that next piece of clay, and I can see he's not grounded, and I may take a little bit more time to work with the clay, and if he's still not grounded, I'll say, what did you have for breakfast? And you can see that we had eggs. Are we doing anger management or talking about my diet? I said, well, this is anger management for you. So he's like, okay, whatever, lady. So he gets the clay and he throws it again and he throws a couple more, then he turns around and he's gone. Did you have the ranchero sauce on those eggs, or did you have... And so I just start asking him questions about something completely unrelated, and you can see the wheels having to get to turn again. And I will help him. I'll say, do you see how quickly you go away when those feelings are up? He goes, oh my gosh, yes. He said, I can go into rage very quickly. I said, that's the problem. That's the problem. You've got to learn how to feel your anger without just taking it off the charts and turning off your brain, turning off your prefrontal cortex. So they have to learn how that feels in their body to be able to go to the certain point and not cross it. Every one of us have emotional parameters that we've built in place over our lives growing up. Every one of us at some point in our lives has said, if one more bad thing happens, one more, I'm going to lose it. And how many of us have had that one more bad thing happen? Yeah, so we start to learn where those parameters are and how far into an emotion we can go. We start learning that and to pull ourselves back. That takes practice. They need to practice in facilities like this instead of practicing out there. So all this value has been given to good CBT. CBT skills are very important. DBT skills are very important. And there's nothing wrong with them, and we need them. But there has got to be an awareness of the value of the expressive component, the expressive therapies too, to help people actually find those feelings in their body that have been trapped. Does anybody have any questions about this so far? Are you awake? Okay, so let's see.
Not surprises, somebody will learn something.
Oh, this was something, I'm sorry, I should have probably gone over this a little earlier. We were talking about the developmental, that people are emotionally, they're physically this big, but they're emotionally about this big. The most obvious diagnosis, any of the personality disorders, when you look at the personality disorders and you think of a little kid, if you think of a kid, I mean, OCD, you have to turn the doorknob 7 times before you feel safe. You have to wash your hands 15 times before the germs are gone. Is that not magical thinking? I mean, how does a child think, first of all? Well, according to Piaget, they're black and white, magical, concrete, egocentric, and they just live in this moment. They don't have a sense of abstract reasoning. They don't have abstract thought. So normal child, black and white, magical, concrete, egocentric, and can just live in this moment. Concrete being, do you remember in the kindergarten example where they have the tall skinny beaker and they have the short squatty beaker, and they take the liquid from the short squatty beaker and right in front of those kids' faces they pour it all into the tall skinny beaker and they set it right back down. It's every bit of it's gone, and they set it down and they say, which one has more water? And the kids are all, oh, it's that one, it's the tall one, because it goes up further. That's it being concrete in their thinking. And that's how kids are, and that's just because of their mind hasn't developed enough to be able to think abstractly. But when you have a lot of traumatic experiences and or your parents didn't know how to help you grow emotionally, like I said, you're going to be back down here. You're going to be emotionally much more stunted, much smaller. So when you think about all the personality disorders, if you would think about, if that was in the section for adolescents in the DSM, you wouldn't bat an eye because it totally fits how that kid thinks. Let's look at borderline personality disorder, which is one of our all-time favorites. So this is a pattern of unstable interpersonal relationships. Okay, number 1, frantic efforts to avoid real or imagined abandonment. Can you see that from a child? Do children have issues or fears of being left? Yeah, totally. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. That is a mouth of mush, but that actually means I hate you, I love you. If you need help with that, walk down the cereal aisle at the grocery store and watch children throwing fits in the floor. My daughter loves me one minute, and the minute I tell her no, I don't like you, Mama, I'm not her best friend anymore. So kids emotionally are very labile. So that absolutely fits a kid. So these are the diagnostic criteria for borderline. Identity disturbance, well, you're 6 years old. Impulsivity, does that fit a kid? Does that fit a child? Now, recurrent suicidal behaviors and gestures, this is more about impulsivity. That suicidal behavior is just, I need to do this because this is the only way I can stop the pain. That's black and white and very impulsive. That's black and white magical thinking. Can't think past this moment. Reactivity of mood. Is that a child 2 to 7? Does that fit a kid? Are kids reactive? Are they moody? Chronic feelings of emptiness. I don't think you see that so much with children. A lot of times what you'll see with kids, they'll use the word boredom. Inappropriate intense anger, transient stress-related paranoid ideation, or severe dissociative symptoms. If you feel a disconnect or if you're paranoid, you fit this criteria. If there's a monster in your closet, it's called magical thinking. If the aliens are following you, it's paranoia. So it depends on what age frame you're talking about, if you want to call it magical thinking or paranoid ideation. But when you look at these 9 criteria, at least 7 of them are right on what you would expect for a child between the ages of 2 to 7. And the research has shown that people that have borderline personality disorder, they have done sexual abuse and physical abuse. And for sexual abuse and physical abuse, I think it was 78.8% of people that have borderline personality disorder fall under having experienced sexual abuse and or physical abuse. Now, I haven't seen the recent research and I haven't done a lot of digging, but if you add emotional abuse, emotional neglect, adverse childhood experiences, or parents that did not know how to manage their feelings, what percentage do you think that would fit for borderline personality disorder? It's going to be 100%. Borderline people do not come from healthy environments. That dynamic does not. You don't get stunted emotionally in a healthy environment. So this is basically, this criteria for this diagnosis is like it's like a checklist, what you would expect to find in an adult that has had painful childhood experiences. And the most difficult thing is, in our field, borderline personality disorder is one of the most difficult diagnoses to treat. I always thought the criteria was just get on your last nerve, trying to cause problems, creating drama. This is the actual criteria. But they're so negatively talked about in the profession. Matter of fact, for years people were told they can't even be helped. They cannot get better. They will not get better. Yes?
Are you saying basically that borderline personality disorder is developmental arrest? Is that kind of what you're
She's saying, what she's stating is, am I saying borderline personality disorder is actually developmentally emotional arrest? Totally, 100% is what I'm saying. And you can see it as clear as the bell. And you can see it when you look at the other personality disorders too. Yes, Dustin?
I read about it as being described as the wastebasket and diagnosis.
Oh, that's terrible. That's even worse than what I've heard.
And so I'm guessing on this too, that what are the age that somebody could be diagnosed with borderline personality disorder? Not adolescents or children, but being adults.
Yes, this is for adults. See, it gets confusing because you would think you could do. I don't want people diagnosing kids as borderline because they all are anyway. That's how kids are. So that's why they don't want you to diagnose children with this. But what we're missing is this is an adult body that went through these kinds of experiences at this age. This is what you would expect.
But not, you wouldn't expect it as adults.
You wouldn't expect what?
You wouldn't expect it as adult, but they still do.
Yes, you don't want to think of an adult acting like this. And when we do, we don't like them. And we put a bad spin on it and we tell them, since we can't fix them and we can't figure out how to do it, therefore they're uncurable.
So do you find that there's a reluctance of professionals wanting to work with people with borderline and in relation to them being able to get help after they've been diagnosed with this?
He's saying, do I see a reluctance in the profession for people to work with borderline personality disorder and not wanting to take on people that have this diagnosis? And the answer to that is yes. For many therapists, if that is a diagnosis that comes out of the person's mouth, they will instantly refer them.
We have an attorney come and speak to one of our grad classes who works for LPCs largely, and said one of the rules to safeguard yourself against liability.
Yes.
Do not take borderline clients.
So what she's saying, for the benefit of the people that are going to be getting the CD, is that there was an attorney that came to them and talked about professional liability and recommended, if you want to minimize your liability as a clinician, to not take on any client that has a diagnosis of borderline personality disorder. He didn't mention family members, right? He just said taking on, right. So yeah, there's terrible stigma. It's not near as bad because the more that trauma-informed is getting out there, and the thing about trauma-informed to me is just the bare minimum. It's what should be there anyway. It's called good therapy, good clinical skills. Trauma-informed means having a general awareness, and it's just like the 30 minutes in the public schools. We'll start there. It's better than nothing. So at least we've got trauma-informed that's kind of come up over the horizon in the last 10 years. In Michigan, actually, there's some state laws where trauma-informed, they started it probably 15 years ago. They want people to be trauma-informed. And that's the bare minimum of understanding trauma and the effects of trauma and how trauma can often precede a lot of these symptoms and diagnoses. And when people ask me if we do trauma-informed, I'm like, oh gosh, yeah, and a whole lot more. We do trauma treatment. It's not just trauma-informed, but it's also trauma treatment. Because trauma-informed is this part, guys. It's explaining things. Just like we had a client here before, and she said, you know what? They explained to me what my trauma was, but they didn't know how or never helped me to actually resolve it. It was just like they explained to me how, because of these situations with my father, it's created this dynamic in my life, which has caused me to need to use alcohol. So they explained the trauma and the effects of it, but they never helped them deal with the body part or get the feelings out. So when someone comes into my office, or when someone comes into this facility, I know right off the bat, if they cannot control their thoughts or behaviors, there's a split in self. There's something that's disconnected this from this. Because, I mean, hello, adult human beings with the minds that we've been given, the brains that we've been given, the education, the knowledge that we have, the advancement of technology, everything that we have, you mean to tell me you're coming into my office because you cannot keep your hand from doing this? I mean, seriously? You can't stop doing this? Is there a gene that makes someone's hand have a tick and they can't stop drinking? No, it's not a genetic issue. We want to say that. It's not a genetic issue. It's not even been identified. There's not been a gene that's ever been identified for this. So people will say, well, it has to be a genetic issue because my great-grandfather drank, my grandfather drank, my dad drank, and I drank. I said, well, I mean, I can see why you might think that, but what do you think about the possibility of your great-grandfather had a hard day in the fields and he came in and drank moonshine? He's all stressed out and he drank moonshine. So his son learns that he had a hard day in the fields. He comes home and he's going to drink whiskey. And his son learns that he has a hard day at the office. He's going to come home and he's going to drink some wine. So it can become a way of life that is learned through the environment as opposed to genetically being passed down. Now, can people genetically be more sensitive to certain things than other people? Well, of course. You can have a sensitivity, but that you cannot think that genetically. And that's where we have to be careful a little bit about the disease model, which is that would be CD number 45. But it's the understanding of the disease model is more about trying to get people, and my understanding of the origins of the whole concept of the disease model is it came from trying to help people get off this moralistic kick where if this person was just a better person or prayed harder or was a better Christian, they wouldn't struggle with drinking like they do. It wouldn't be an issue. You don't have any discipline. You need to have more discipline. So there's all this moral judgment. And the thought was, wait a minute, would you blame someone over here if they had cancer? No, you would not. You've got to understand this is more than just a character that this is a defect in themselves. You have to understand there's more to it than that. There's something greater than that going on. And so that was used originally to get people off of that judgment, that moral judgment. Because there's not diseases out there, true diseases, if you use a true definition of a disease, there's not a lot of diseases that if you follow 12 steps, it makes it stop. Now, does that mean that we don't support 12-step? No. 12-step is the philosophy, you can't get better than that. You're not going to get those 12 steps are invaluable life resources and tools for yourself, and they're things that everybody needs. Everybody needs, I believe. That philosophy is something everybody needs. But if you use the disease model to convince yourself that I have no control over this whatsoever, therefore I'm just genetic mutant, and the only thing I can do is take my medication, or the only thing I can do is just stay away from bars, and that's the only way I'm ever going to have any kind of relief, I think you're shortchanging a person. There's a lot more that a relief they can have. Life shouldn't have to be about white-knuckling every single thing just to make sure you don't do this again. Let's get to the taproot underneath all of this that's driving those behaviors. And the discipline can come. The 12 steps wraps around you and gives you the discipline and the philosophy for how to get to this. I think they're very, very intricately woven. But I want to talk about the disease model because I don't want people to think that we don't understand that. Does it affect the brain? Does addiction affect the brain? You bet. But something can affect the brain without it being a gene. We can be chemically altered. People say, well, I have chemical depression. It has to be genetic. I'm like, no, you can have chemical depression. I mean, if you think happy thoughts, do you feel better about yourself? Can you feel a difference in yourself if you're saying negative, horrible, shaming things to yourself versus saying positive things? Yeah, there's a chemical change. Doing this is a chemical exchange. Everything in my body operates off of chemicals and energy. Everything. So do I believe that addiction affects a person's brain? You betcha. Do I believe trauma affects a person's brain? Yes, I do. Are a lot of the areas that the trauma brain is affected by and the addicted brain is affected by are very similar? Yes, they are. Is there an overlap between trauma and addiction? Yes, there is. So does it affect your brain? Yes. Does it affect your chemicals? Yes. Are you a genetic mutant that all we can hope for is that you take your medication or you never get anywhere near there's alcohol because you will not have control? No. There's more to it than that. From our philosophy. That's our philosophy. So, going back to the gentleman that comes in my office, he's a grown man. He's educated. I have doctors, lawyers. I have had this happen in the last 25 years too, where I've said to someone, you don't have to be a rocket scientist to understand this. And we went around the room and some guy we were talking about different things people do, and he said, I'm a rocket scientist. I'm like, oh, well, every time I'm going to have to come up with a better example. I said, but what kind of rocket scientist are you? So, and there's a split between that person, what they think and what they feel, or what they think and what they're doing. There's an unintegrated sense of self. There's a dissociation, and I mean dissociation in the loose context. I don't mean it in the narrow context in psychiatry, dissociation. I mean, it encompasses that, but the dissociation means literally disassociated. There is a disconnect between that person's mind or that person's body, or the person could control this for Pete's sake, or control this, or control sticking your finger down your throat to vomit, or control acting out other ways. We could control that if there wasn't a disconnect between mind and body. So if someone can't control their thoughts or behaviors, you know right off the bat, there's an unintegrated sense of self. There's a disconnect between mind and body. And people will say, my body has its own mind. They'll even describe it as two separate minds. And you'll see this evidence in their black and white thinking, their inability to tolerate and recognize a feeling. They can't even recognize their feelings, much less tolerate a feeling. And if you can't tolerate one feeling, you sure as heck can't tolerate a mixture of feelings like ambivalence. Ambivalence is a mixture of feelings, but actually, the key to, when someone says, Melissa, what's an emotionally healthy person? What does an emotionally healthy person look like? The answer I would give is, an emotionally healthy person is someone who can tolerate conflict. I don't mean conflict, I mean conflicted feelings, where the ambivalence, that rub, that emotional rub. Someone who's emotionally strong or healthy is someone who can tolerate conflicted feelings. You actually want to, that's what objectivity is. Someone can say, well, I can see that, and I can see that. I can see both sides of that. Objectivity keeps us from getting too heavy on one side or the other. What we've learned over the years is the person that's very, very angry, let's say goes to rage too much. People who go to rage too much, the antidote for that person, the way to help that person, is you've got to bring in some feelings of sadness, vulnerability. The more rageful people are, the more afraid they are of their own sadness and hurt and vulnerability. So the rage covers up sadness and hurt. So when I go to anger management, one thing for that gentleman, when he's so angry and I'm saying, what'd you have for breakfast? If I can't keep him out of his rage, I will say to him, let's do something different. And I did have a man one time. He came in there and he got court committed to us. He had broken his best friend's back in a poker game. He got so mad at him. He had sent his wife to the hospital multiple times. He had knocked out her teeth. He came to us to do anger. He came to a program because he had trauma, and part of the program was anger management. And I can remember I had just started. I'd been doing this probably a couple of years, and he was court committed to the program. And I remember thought, my gosh, I'm going to be sick on that day. I don't want to go. I don't want to do anger management with that man. And so when it came to, and the whole time he was in the program, he was so quiet and so soft-spoken and so sweet and so helpful. And I just kept thinking, where is the man that broke his friend's back? I mean, there is a raging, angry man in here, and I've yet to see him. So I remember when he found out we had a group called Anger Management, and he was so excited. I wasn't. He was very excited. So the day it came up, I was like, oh, I don't want to go to work. And I get there, and he's so excited. He said, can I help carry the clay? I'll carry the bucket. It's like, okay, sure. So we're walking down the hall, and I'm just talking to him. I said, now, tell me what's your wife's name? He said, well, my wife's name is Mary. And what's your dog's name? He said, well, my dog's name's Spot. And you have a cat? Yeah, I have a cat. His name's Lucky. So we're just chatting nervously as we walk down to the gym, and I know I've got to do anger management with this man. And I remember he picked up, and we went over all the rules, and I talked to everybody, and I said, are there any volunteers to do anger management. And he's just like, oh. And I'm like, is there any other volunteers that want any? I was like, okay. So he comes up with me, and I'm standing with him, and I remember the whole group is watching him, and he's just as nice, and nobody expects anything because he's been so polite and helpful the whole week. And so I hand him one piece of clay, and he said, what do you want me to do? I said, well, I'll show you. I said, I want you to take this clay, and I want you to practice getting this strong energy up. And I want you to say, I'm angry. I want you to invite that energy up, and I want you to throw that clay. So he said, show me. I said, okay. So I said, I'm angry. And I threw the clay, and it hit the board. He's like, oh, okay, I can do this. So I give him one piece of clay, and he takes it, and he looks at the board, and he turns to the side, and he starts winding up like a pitcher, and he screams and throws the clay. I thought the board was going to split in half. I mean, you look over, and all the clients are like, everybody is terrified, and he reaches out for another one, and he's gone. I mean, he is nowhere in there. And I'm like, so I start talking to him. I ask him, what's your dog's name? My dog? Spot. And your cat's name? When your cat's name? Mary? No, that's my wife. Okay, what's your cat's name? It's Lucky. Oh, okay. He said, can we do anger management? I said, oh, yeah, sure. So I give him another piece of clay. He turns around. He does the same. Bam! And it's loud. He is crazy looking when he turns back around. At this point, all the clients are like, everybody's shoveling over into the corner. So I start talking to him again, trying to get him grounded. And he's like, oh, and he has to really think. And I said, do you see how quickly? I mean, like that, you are gone in that rage. I said, this is why you're here. This is what got you here. And he said, well, I don't know how to do it. I don't know how to not go there. I said, let's try something different. So I said, I want you, and I'd already read his chart, and I already knew about his father, and I already knew about the abuse that he had. And I knew his father was sexually abusive. He was horribly abused. So I said, okay, I want you to do this. I want you to put the clay in your other hand, in your non-dominant hand. And I want you to toss the clay. And I want you to relax your spine. You don't need this. I want you to relax your spine. And I want you to toss that clay at the board. And I want you to talk about the dad you wished you would have had. And he said, what do you mean? I said, tell me about your dad. He said, he's a son of a bitch. And I said, okay, tell me a little bit more. He said, he's a real son of a bitch. I said, okay. Tell me about the dad you wished you would have had. And he goes, what do you mean? I said, just tell me about the dad you wished you would have had. He said, I don't know. I didn't have him. It doesn't matter. That's not who he really was. I said, I understand. I know that's not who he was. But under the umbrella of dad, there's also who you wish your dad would have been. Not just who he was, but who you wish he would have been. And he said, you mean like a dad that would like come to my baseball games maybe every once in a while? I said, yeah. What else? And he said, I mean, like maybe tell me he's proud of me. And he just starts sobbing. I mean, it was so quick to get him there. And so I said, now put the clay in your left hand and talk to your dad. And he said, I just wanted dad to love me. And he's very relaxed. And the energy's totally different. His spine's relaxed. He's throwing the clay. He said, I just wanted dad to love me. Just wanted him to tell me he's proud of me. I just wanted him to tell me that I just wanted him to come to my games. And he just kept talking. And he was just tossing the clay. And he was very much sad. And he sobbed and he sobbed and he stood there for a minute. And I stood right there with him. I said, I'm right here. You're not going through this by yourself. And he just sobbed and sobbed. And he got a few more and he kept throwing it. And then finally he turned around and looked at me and he said, Melissa, please, can I just throw one from rage? What was he doing? And I almost felt sorry for him. I almost want to say, okay, why do you think he was asking me that? Why did he want to throw that clay from rage when he was in the middle of all his tears? Oh my gosh. He couldn't stand how that felt. And I said, I'm sorry. We'll call him Joe. I said, I'm sorry, Joe. I can't do that. I can't let you do that. This is what you've got to practice feeling. This is what you've got. He goes, but this is when I drink. This is when I want to drink. Well, I want to drink. You're causing cravings right now. He said, this isn't helping me. You're causing cravings. So I said, this is what you've got to feel. This is what's behind the drinking. This is what's behind the rage. This is what's behind your arrests. This is going to continue till you get more comfortable with this. And he said, well, this just sucks. And I stood there with him, and I got 2 chairs, and I sat down beside him, and he just sobbed. He just cried and cried and cried. And afterwards, he felt better. If I had let him, do you think he would have shut all that right back off and gone into the rage? Absolutely. And at a lot of places, they don't know when they're doing this kind of work. If someone is too rageful, I've got to start helping them. The greatest feeling that they're the most afraid of is their sadness and vulnerability. So the bigger the rage, the more terrified they are of the sadness. So where do I need to go in therapy? Do I need to go work with him on his anger? Yeah, A+. He wrote his PhD, his dissertation on rage and anger. He doesn't need help with that. He needs help with the sadness and the hurt. So most therapists, if someone comes in and they're struggling with their anger, they've got to help deal with their anger. And they go in at the anger. That's just the surface. That's just the veneer. Go deeper. The feeling that he needs to work through, that he needs to practice getting desensitized to, because he's so afraid of it, is the sadness, vulnerability, hurt that's down here. And I've had men that would throw that clay, and I'd try to talk to them about their dad, and they couldn't get in touch with the sadness. And so I couldn't get through their head. I was trying to talk about the dad they didn't have. They wouldn't talk about it. They wouldn't go there. They just stayed mad. I said, okay, well, let's do something else. Put the clay in your left hand, in your non-dominant hand. He's like, okay. But bam, they can still throw it just as hard. I said, okay, now I want to put the clay in his hand. I want you to underhand it on the board. This is one guy in L.A., in our program in California, years ago. I'll never forget this. He was a bodybuilder. He was huge, and he was angry all the time. And he wasn't sad about anything. So I had him throw it this way. I had him put it in the non-dominant hand. He had just about as much power that way. I had him underhand it. He could nail it that way. And I said, okay, I want you to turn around. He turned around and said, I want you to throw it over your shoulder. He's like, then it became a game, right? Like, okay, I'm going to show this chick that I can hit this board as hard as I can. And he, bam, he hits it as hard as he can. So, and the whole group's just sitting there. And so I'm thinking, it's almost like the bull at the bullfights. How do I break down? How do I get this man to break down? Because he can use his body as his escape. His addiction is his body. He avoids his feelings through his strength. So I said, okay. Non-dominant hand? He said, okay. I said, raise your leg, toss it under your leg. And at this point, they're all just cracking up. He raised up his leg and he threw it, and the clay shot way over there. He didn't have the control. He burst into tears. People didn't even realize what was going on. They thought he was laughing. I'm like, no, he was sobbing. So just to break down the control in his body got him into that vulnerability. Many of us start to experience, as we age, not that I have, but as we age, we start to experience changes in our bodies, and we don't have as much control over things anymore. A lot of people don't need to do any kind of emotional work until they get sick or they have a chronic illness. And once the body starts to let them down and they can't control things anymore in this body, there's a sense of helplessness. Same with people who struggle with any kind of chronic illness, cancer, anything. It's a helplessness in your own skin, and that's a pretty helpless place to be. And that will stir up a lot of painful times from your childhood. So I've had a lot of people that once they got sick or diagnosed with something or had something they just couldn't get over, or they had a car wreck and they broke a limb, and they didn't have, a lot of people come into therapy after something like that happens because it opens up the emotional floodgates for them. Now, on the flip side, for someone who's very depressed, the only diagnosis that I really like, that I think is clear-cut, to the point, makes perfect sense, tells you what you need to work on, is major depression. We don't have a major anger. I wish we had a major anger diagnosis, but we don't. Major depression is the only one that really captures exactly what we need to look at. So here's a person, and if I see that they've had a history of major depression, I don't even have to meet the person. I can tell you right there, this person's terrified of their anger. They're terrified of their anger. They're so afraid of anger, they won't even get close to anything that has strong emotional energy that could even resemble anger. So they don't want to go anywhere, around any kind of intense emotion or strong feeling. And people who can't handle a strong feeling are going to be very gun shy of self-esteem, setting boundaries, standing up for, literally, people that are depressed are usually like this. They don't even know how, people will say, get a spine. Where's your backbone, kid? You'll talk about, there's something to embracing that energy in your body because it stands you upright and you look people in the face. And so for people who are very depressed, they're so terrified of their anger. And people come in and say, oh, I need to help this person get in touch with their sadness. No. Dissertation time again. They've got a PhD over here. We don't need to work on their sadness. We need to work on their anger. Not their rage, but their anger. Because when someone's depressed and you apply a little bit of anger, it will pull that depression up. So I'm talking to you about energy states right now. So we're talking about feelings, but I'm talking about balancing energy states. When people come to us, energetically, they're off balance. This kind of language works better in California than it does in Texas, but energetically, they're off. I'll say that here when I'm presenting in Texas, and I always get these looks at me like, whatever. In California, they're like, oh, yeah, I get that. So we literally are looking at where the energy is stuck, and we're talking about energy that's off balance. So if they're depressed, you want to go for the what? Anger. If they're too angry, you want to get them in touch with what? Sadness. Now, are they going to push back on you and not want to go there? Yes, because that's a very uncomfortable state. But you got to practice that. So now the person that comes in that's bipolar, they're my favorite. People that are bipolar, they're able to go to both poles, and they're able to say, well, Melissa, I don't think I need to be here anymore because I can do my anger and I can do my depression or sadness. I can do both of those. I really don't need to be here. I said, yeah, but what you don't do anger, you go into rage, and you don't do sadness, you go into depression. You've got to learn how to get right here in the middle. You're actually one step ahead of your friends that struggle with major depression. Bipolar means you're getting closer because at least you've got two poles now instead of just one. And for a lot of people who come in who are in this very angry place, when they start getting in touch with their sadness, they'll fall into a depression because it's like a pendulum. It's almost like we don't know how to get in the middle. So we'll go from one extreme to the next, and then people learn how to get there more in the middle. So the goal is, so if someone's bipolar, I'm like, yay, you're further along. What we've got to do now is teach you how to feel both those feelings at once. And so for the person in anger management, what that will look like is the person that can say, I hate you and I love you, or I'm angry at you and I miss you. And it's not rage, and it's not this little soft throw either. It's this real, just very focused, it's strong. They're able to hold both those feelings at the same time, and you can feel it from the person when they're doing both. It's just like what you saw yesterday with that young man. When we called up that energy state, you can see it in their bodies, you can feel it. We're so afraid to feel or to give ourselves permission to connect with our clients from our bodies, from that feeling place. But we've got to. That's why Dr. Ross and I have worked together for so long, and I think worked together so well, is because, just in case y'all didn't notice, if you had to guess, would Colin Ross be an A, cognitive therapist, B, cognitive therapist, C, cognitive therapist, or D, all of the above? It's not hard. It's not hard. It's not hard when you see me present to figure out, I prefer the expressive. I prefer the experiential. Doesn't mean I don't ground them cognitively. And when Colin does cognitive therapy, it doesn't mean that he doesn't get them in touch with their feelings and their body. So if you prefer cognitive therapy, that's fine. But if we're not careful, if you just keep people here, because what happens is, as children grow and learn, if they don't have someone to teach them how to deal with their feelings, they understand their bodies. Everybody from the age 8 on up understands this. Understands if you get a cut, it's going to bleed a little bit, and it's going to scab over, and it's going to make a sore, and it's eventually going to go away, or you get a bruise. Everybody understands this. We can touch this and feel this. And when we're talking about people who are black and white, magical, concrete, or egocentric that are this big, when you talk about normal childhood development, they understand this. This makes sense. You can touch this. They have what I call physical integrity. They know what it means for their body to get hurt, and they know how to self-soothe, how to use their thoughts to help self-soothe the pain in their body. We all have that from probably about the age 8 years on up. So our clients have physical integrity. They've just experienced that, and they've developed that. But they don't have emotional integrity, which means they don't know how to recognize their feelings in their heart, and they don't know how to self-soothe their feelings with their thoughts. So when you have physical integrity but you don't have emotional integrity, an interesting thing happens. There's a dam that gets built across your neck, and brick by brick this gets laid, and this gets separated from the body. So the head and the body become very separated. So anytime someone has all these painful feelings come up, and they don't have emotional integrity, so they don't know how to process them, but they have physical integrity, they're going to push it into the only thing they know. And when you're black and white, magical, concrete, and egocentric, and you're emotionally this big, you're physically this big, but emotionally this big, when painful feelings come up, what you're going to do is you're going to cathect them or push them into what you know, which is this. So let's start with an obvious. Is self-mutilation, is that a physical expression of emotional pain? Yes. Self-harm is a physical expression of emotional pain. What about drinking alcohol? Is that a physical expression of emotional pain? Yes. What about eating or not eating? Physical expression of emotional pain. What about acting out sexually? Physical expression of emotion. So I've never liked the statements, he's addicted to alcohol, because that's so trivial. It doesn't tell us anything. It's so surface. It's just at the veneer. It makes better sense to say he's addicted to avoiding his feelings by drinking alcohol. She's addicted to avoiding her feelings by not eating. He's addicted to avoiding his feelings through gambling. It makes more, the addiction is to actually avoiding the pain. That is actually what the addiction is too. It just happens to be you have to keep doing X, Y, or Z to keep the emotional pain pushed down. So the addiction isn't necessarily to the process or even the substance. Now, we can become physically addicted, or biologically, or chemistry can be addicted to it. But on an emotional level, you are actually addicted to suppressing the pain with the alcohol, with the sex, with the drugs, with the eating disorder, whatever it may be. So core clinical assumptions. This is the second core clinical assumptions that we're going to talk about. The first core clinical assumption was an unintegrated sense of self, where mind and body are separated. And you'll be amazed at how often when you ask your clients, do you ever feel like your head and your body are separate? Do you ever feel like your body has a mind of its own? I asked that question yesterday in group. I said, do you ever feel like your head is separate from your body, or as if you're floating? And every single person raised their hand. That was actually a little bit surprising to me, that every person in that group, including staff, no, I'm kidding, every person in that group raised their hand. So there is a disconnect. There's absolutely a disconnect. And so the whole point of is that there's already a disconnect between mind and body, and there's already this kind of dam that over the years, brick by brick, has been laid across their neck, and the only thing they know how to deal with their painful emotions is to redirect it back down. They don't know how to have their thoughts and their emotions connect, because there's a disconnect, there's a break between the two. If you only do cognitive therapy and you don't get them connected to their body and their feelings in their body, you're colluding with that brick wall. You're colluding with that defense mechanism, and you just keep them up in their head. Or if you go into their body and it's just about like vomiting all of this out. When we first started doing art therapy, I was criticized by some of the art therapists that weren't working with trauma survivors, I might add. Some of the art therapists were saying, you're too directive, because I will write the directions on the board of how I want them to do the assignment. Now, how they choose to express those directives, I don't interfere with that. But I'm pretty directive, because I can't make the mistake of just thinking that it's therapeutic when people come in there and they slap all this paint on this paper or get all these pastels and they purge all this emotion out, and they're completely dissociated. The first time I had a group do that and they were just getting all this out, 2 of them were under the table. Somebody else ran screaming out of the room because they had red paint on their hands. Everybody got triggered. So you have to keep them grounded here. Even if you prefer the expressive techniques, you have to keep them grounded here. And if you're doing cognitive, you've got to get them connected with the feelings that they have in their bodies as well. So we're all the time looking for how to bring those two together. Some people, talking to them, talking about feelings doesn't budge them. I've had some people that are so depressed and they sit in the office like this, and these are the folks that I almost fall asleep sitting in the office with them. They have absolutely no energy. They're so shut down and turned off and closed in, and they're pulled in. Sometimes talking to them, you can't get the energy there. So I've actually asked people in my office before, I said, I want you to do me a favor. I want you to push your back into the back of the sofa. Put your spine in the back of that chair. And you'd be, okay, well, that's a start. Okay, I want you to put your shoulders into the back of the sofa. And I actually had one time in my office, we stood up and I said, okay, I said, I'm going to put my back against this wall. And she had her back against the wall. I said, okay, now put your shoulders against the wall, put your head against the wall. And we're like, oh, I can't stand how this feels. It feels so vulnerable. So you can go through people's bodies. I had one guy that was all up in his head, and I could never get him in touch with his feelings until one day, accidentally, he came to me after he'd been to his chiropractor, and he was a different human being. So I started scheduling his therapy sessions after his chiropractor, because when he goes in for his adjustment, are they going through this man's body? Yes, they're going through his body. And when they went through his body, it opened up stuff, and it was much more malleable by the time he got to my office. So a lot of times, if you have people that are all up in their head, you're going to want to try to direct them into other, and most people that are up in their head don't want to do yoga, art therapy, psychodrama, because they will judge it as being piddly or minimizing it. They'll minimize the value of it because they want to have the control, and the control's all up here. They want to just go to cognitive therapies. They just want to learn everything. They don't want to get in touch with the feelings, and they're usually the people that need to be there more than anybody else. So it's a great artistic skill, I would say, in teaching and coaxing and getting people, and I will say to them, when they come to art therapy, I don't care what your drawing looks like. This is not about the product. I could care less what the picture looks like when you're done. This is about the process of art therapy. It's not about the product. And they show that when you talk, you use a certain part of your brain. When you write, you use a different part of your brain. When there's movement, you use a different part of your brain. And when you draw, there's a different part of your brain. And we're trying to get all parts of your brain to be integrated and to be able to get this experience while you're in this program in as many different avenues as we possibly can. So if you can put a brain twist on stuff like that, a lot of these cognitive heavy people will buy into it a little bit more. But they're the ones that need it more than anybody. So I think I've beaten this horse to death. I think people are starting to understand in this program, because I've been over it and over it and over it. If you have that divide across your neck, you're going to wind up pushing everything in your body, because you can't afford for it to come up here, because this doesn't know how to self-soothe this. So you just cap it and keep it in here. Matter of fact, if the feelings come up and connect with this, what's going to happen is there might be some memories. There might be some things from the past that surface. So that's another reason why people don't want their head and their heart to come together, because they don't want to have to remember the stuff that they've tried so diligently to forget. So that's another reason why those two don't want to come together. So when you don't want mind and body to come together and you don't know how to deal with your feelings, the name of the game is, how can I avoid this? If you touch a hot stove, you're going to pull your hand away, just automatic. Nobody likes painful experiences. But you have to learn that there are some things in life that are going to hurt to get you to where you want to go. If you want to be able to lift 50 pounds with this dumbbell, when you pull this arm up, if it hurts, you go, ow, 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 I can't do that, it hurts. Now, why can't I lift 50 pounds? Because you're going to have to experience some discomfort for that muscle to know it needs to get stronger. The same is true with emotional muscles or emotional memory. You've got to learn, you've got to be able to build up the emotional muscle, and that's going to be uncomfortable. But I don't want to be uncomfortable. I want to take a pill. I want the pain to go away as quickly as I can. So that's something we have to battle with and remind clients, you're going to feel uncomfortable. You're supposed to feel uncomfortable. If you don't feel uncomfortable, you're probably not getting the most for your money while you're here. You need to feel uncomfortable, because this is what's coming up now, since you can't drink while you're here, since you can't use while you're here. You've done all those things to keep all that suppressed. So now it's coming up on you. This stuff is opening up, and you're going to feel uncomfortable. That means you're doing it right. So let's look at all the ways that people can avoid, because it's quite amazing and it's quite extensive. And this is just, the treatment objective here is, this is the objective for everybody, and I've just about got all the clients appropriately brainwashed. The objective is to feel my feelings and stay safe. So if it's, and some people can tell you, some people can say, well, when I get angry, I drink, or when I get sad, I overeat, or when I get scared, I self-mutilate. Some people know exactly the feeling that precipitates the destructive behavior. Some people don't. You're just having to teach them what they feel to begin with. Some people, you kind of have to walk back. If people say, I drink for no reason, or I have no reason for my eating disorder, that's not accurate. There's always a reason. They just aren't able to identify what the trigger was in the beginning. It's always there. It's always there. And sometimes you have to back up with them and say, well, didn't you have a phone call with your mother this morning? Well, yeah, but there wasn't anything that, I just really have a craving. It's not really connected to anything. Well, how did your conversation with your mother go this morning? Well, I mean, it's the same old, same old. I mean, she told me she wished I'd never been born, that I'm a disgrace to the family. I'm like, okay, well, that probably felt kind of bad to hear that. Well, yeah, but she says it all the time. I just think, I really want to drink. I don't know what it's about. Sometimes you have to really help people put the pieces together to find the triggers. They're always, always there. So an objective is to feel my feelings and stay safe. For the person who drinks when they're angry, their objective would be to feel my feelings of anger and not drink. If someone overeats when they get sad, they're going to have to learn to feel my feelings of sadness and not overeat. So this objective applies for anybody regardless of what their diagnosis is. That's the overall objective. Then you can kind of customize it depending on what it is that they're doing. So let's look at all the different things that people do to avoid their feelings. Drugs and alcohol, self-mutilation, medication, sex, intellectualizing, shame. People can be addicted to shame. Those are people that tend to get caught in the victim role, and they use that role, they use that place, not intentionally. None of this stuff is done on purpose, but it's a way to go into these places to avoid deeper feelings. Shame, believe it or not, if you've been shamed for so many years growing up, it's easier to hate yourself and beat yourself up and shame yourself than maybe it is to feel the grief about the parents that you never had. So if you see people that keep bringing shame back to themselves, that say, you know what, you're addicted to shame, you're overdosing on it. Matter of fact, everybody in this program is overdosing on shame. It's in there. Being a drama queen or king, entitlement, denial, eating, not eating, dissociation, alter egos, extreme collecting, confusion. You can see shoplifting, masturbation, promiscuity, flashbacks. Now, if we had more time, I could give you examples of a lot of these and explain it more in detail. We'll do that at another training where I'll go more into detail. People get the gist of what this is. It can be anything. It can be knitting. There can be people who are addicted to knitting. And I gave the example before of the lady in the program at the hospital who loved to knit. And she could knit. She would knit a king-size comforter by the end of the day. The whole day she knitted throughout the whole entire groups. And it was beautiful stuff. I said, you could sell this stuff on eBay. This is really incredible. She was very skilled, very artistic. And one day I told her, I said, you know what? I'd really like for you just this one time to leave your knitting stuff in your room. And she looked shocked and she said, my therapist said that this is a very good outlet. And I said, well, what is? I'm not taking it away from you forever. I'm just saying for 1 hour, can you please just come to the group and focus on what we're talking about? She goes, well, I focus on what y'all are saying. I focus on what you're talking about. I don't have to leave my knitting stuff. It actually helps me concentrate. I said, well, yeah, but you're real focused on this. It helps me concentrate. I said, well, let's just try. And this is a lady who had tried to kill herself in some pretty heinous ways. And she was just as pleasant as pie the whole time she was there. No one could ever see the anger. And I said, if you're trying to kill yourself, is there suppressed anger? Yeah, because that's about the meanest thing you could do, right? If you lived through it, you'd be arrested. So it's illegal. You shouldn't try to kill yourself. You can't do that to somebody else. You kill somebody else, you go to jail. So it's a very hostile, aggressive behavior. And we never could get in touch with her anger. So finally I said, I understand it helps you concentrate, but sometimes when people are knitting, the repetition, because repetitious behaviors can promote disconnect and promote dissociation. When you think about the little kids that will rock and tap their heads, there is a repetitive movement. That repetition helps you disconnect from your mind. That's why that happens. So I said, when you're knitting, it kind of helps you to disconnect, and I want you to be real focused. And she got so mad. And she said, I cannot believe you're not going to let me do this. And she just threw a fit, and I said, this is what we need. She said, what? I'm pissed at you. I said, well, we'll start there. This is what you need, because you've got to get this anger out. This anger is literally going to kill you. And you can stay here and you can knit this away the whole entire treatment time, or you can actually start learning how to deal with your anger. And this is a good start. And you could say she's addicted to knitting, because she was. She was knitting her anger away. And they don't have KA for her to go to, but she was using knitting in the same exact way as alcohol. She was using it in the same exact way. So anything, hobbies, anything, anxiety, you can be addicted to anxiety. And that sounds kind of weird to say that you're addicted to a feeling. Can you be addicted to rage? We've already talked about that. What's rage help you avoid? Sadness, hurt, vulnerability. So absolutely. You can be addicted to anxiety because anxiety is very physical. Your heart's racing, you can't catch your breath, you have pressure on your chest, you're sweating, you're pacing. That's a very physical activity. Sometimes it's much easier to deal with the physicality of stuff than it is to deal with the emotions underneath it. So this isn't, and I'll tell people, it's not like you choose to have an anxiety attack, like it's a walk in the park or something. It's the lesser of two evils. And what it tells me is the pain under here must be tremendously painful because anxiety is the better option. Your subconscious will take you to the better option. So it's the lesser of two evils. And people can usually grab onto that. Most people can understand that. It's the same with flashbacks. So gambling, pornography, workaholism, perfectionism, shopping, humor, all these stuff, religion, exercise, arrogance, all of these things can be places to escape painful feelings. Because ultimately, addiction is a pervasive pattern of avoiding feelings. Both pieces have to be there. You do it one time, it's not an addiction. You do it over and over and over, you're looking more at addiction. Now, I eat 3 meals a day. I don't like missing them. I enjoy eating 3 meals a day. Is that an addiction? Because I do it. It's a pervasive pattern.
It's necessary.
Well, yeah, and it's missing the second piece. There's a pervasive pattern, but it's not avoiding feelings. Now, if I had a rough day at work and I think, that broccoli and that baked chicken just does not sound good to me, I think I'm going to, no, better yet, I'll go to Brahms and I'll get a banana split. There's nothing better than ice cream on bananas, and I'm going to go to Brahms. If I do that one time, is that an addiction? No, I'm doing it to avoid feelings. I'll gladly state it. It was a crappy day. I really want to go have something that I can just enjoy, which is my food. But if I started doing that consistently, and I started having consequences like I can't get my pants buttoned, is that starting to go into addictive behaviors? Yeah, because there's both there. There's a pattern and there's avoiding feelings both there at the same time. So addiction for us, we use a broad-based definition of addiction. It's a pervasive pattern of avoiding feelings, and we don't have too terribly long time to go through all that. So we're actually just going to have time to do this slide. I've given you a lot of other slides to look at, but we're not going to have time to go there. Typically, when we do the certification process, we do it for 2 days. We do the same thing tomorrow, and I go over this. So a lot of what today I'm cutting out that I would go into longer, but you're going to be reading in the books and stuff. So Colin gave you some books to read if you're interested in getting the certification piece of this. So the spectrum of emotions. This is something that was put together by the clients and myself over the last 20 years. And it started with the best thing, because I told you that I didn't have, in graduate school, no one taught about feelings. No one ever talked about feelings. I mean, they talked about feelings, but no one taught us specifically about feelings or how to explain feelings to people. We're just supposed to help people with their feelings. And what I learned over the years, the best example we have of feelings is that silly little chart that says, how are you feeling today? And it has all those little faces. That's it. I mean, that's really it. That's about the education for how are you feeling. And so I started learning, let's go backwards for a minute. Can you always control what thought pops into your mind? No. Have you learned, though, that you can kind of control what you do with your thoughts if you ruminate on them, if you go over it and over and over it? Yes. Are there some thoughts that are healthier to entertain than others? Absolutely. The same exact thing is true for feelings. I don't believe you can always control what feeling gets triggered. And I know some people will say, he didn't make you feel that way, you chose to feel that way. And I understand what they're saying. I don't totally agree with it. If someone comes up and kicks me in the shin, there's going to be a feeling that comes up in me. There's going to be a response, because a feeling is pure energy, and it's a way that you interchange and exchange with your environment. It's a way to connect with your environment. It's a signal system. So if you get kicked in the shin, you're going to have a feeling. What they're meaning when they say, he can't make you feel that way, you chose to feel that way. What they're meaning is how you choose to act on those feelings. It's not the feeling. I don't think you can always control the feeling. So just like thoughts, you can't always control what feeling pops up, just like you can't always control what thought pops up. But you can start to learn that you can express your feelings in ways that are better than others. But here's what's interesting. Are there some thoughts that are healthier than others? What did we say? Yes. There are some feelings that are healthier than others. Matter of fact, a lot of the stuff that we've called feelings, oh yeah, I forgot, there were 2 things I learned in graduate school. One was that chart that said, how are you feeling today? And the second thing was, all feelings are okay. That was just the standard phrase. All feelings are okay. I never say that anymore. I never say it because I don't believe it's true. There are healthy feelings and there are unhealthy feelings. There are healthy, that would be like telling somebody all thoughts are okay. Well, I'm thinking about killing you, except for that one. All thoughts are not okay. And to ruminate on them over and over are really not okay. You want to lean towards healthy thoughts. You want to lean towards healthy emotions. So what's a healthy emotion? When I ask people that, they're like, well, happy and joy. And healthy doesn't necessarily mean fun, right? Or even pleasant. So if you look at the spectrum of emotions, these are what I'm calling healthy feelings. Or I'm sorry, unhealthy feelings. These are unhealthy feelings. These are healthy. In this side, you can get stuck in your mind, in your logic. On this side, you can get stuck in your body and your behaviors. This is usually dysfunctional patterns of disconnect through under-responding and dysfunctional patterns of disconnect through over-responding. So healthy is where we want to be. Fluid means you can move through it. You don't get stuck in it like you do here and here. Mind and body are together. Over here, you're just in your mind. Over here, you're just in your body. They're grounded in the present. These typically are in the past. That should have been on that slide, actually. They should say ungrounded in the past. And they're not, and they're integrated and connected. So this side is you're all in your head and you under-respond. This side, you're all in your body and you over-respond. So it's like too hot, too cold, just right. Right here is the healthy feelings. These are what I refer to as feelings, right there, that middle column. So let's look at this. If you are someone that makes mountains out of molehills, you're a drama queen, a drama king, a crisis junkie, if you ramp things up and you overreact to a situation and you grow them up, we're going to call too much anger what? Rage. Too much sadness is depression. Too much hurt and pain is despair and hopeless. Too much vulnerability is helplessness. Too much happy is mania. Too much guilt is shame. Too much fear is terror. Too much lonely is abandon. So you can see that these are the healthy feelings, and this is like these feelings grown up, too big. Right? Or you can minimize stuff. And when you minimize stuff, you just tell there is no feeling. You're numb, disconnected, numb, 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 numb. So too much, too little, just right. So if you make mountains out of molehills and you ramp a feeling of anger up into rage, and mind and body is together in a healthy way, if you go here, what do you lose? Your mind. Now, let's think about that for a minute. When someone is enraged, truly enraged or depressed or hopeless or helpless, when someone goes into this extreme place like this, when someone's enraged, can you see that in a person? Yes. Do they wear it? Yeah, their body shows it. When they're truly enraged, you can see it. When someone is depressed or hopeless, despairing and helpless, when someone's in that place, can you see it also? Yeah, you can see these emotions or these states. You can see these emotions. Mania, you can see them. Terror, panic of people. When people go full tilt in these, you can see them. Why? Because they wear them. They become them. They display them. They're in their body. They actually are acting out. That's where acting out comes from. Acting out means you are in your body acting out what you should be feeling right here. That's where acting out comes out. That's what it means. So I don't even call these feelings anymore. If you wanted to put like a little bracket, I'd call these actions or behaviors. Those are behaviors. They're not even feelings. They're actually behaviors. We don't want our clients going here, because if they go over here, they're losing their what? Right, and we want people to, these are feelings. This is a healthy feeling right here. These are feelings. So if I'm going to teach people how to get in touch with their feelings, I better know what healthy feelings are. This is our goal, is to be right here. We don't want them to go here, and we don't want them to go here. This is where we want them to go. Well, think about it again. You hear people say, we're back over here. We're going to go to the extreme side first. All in their body. Their mind is turned off. Their mind is turned off. Okay, well, let's think about that. You've heard people say she was out of her mind with depression. He flew into a blind rage Do his eyeballs literally stop working when he gets enraged? No. But this turns off, right? He's not thinking straight. He can still see. He's not like running into walls. He can still see.
Just can't see what he's doing.
Yeah, he can't think. His mind's gone. Or, here's my favorite, she was beside herself. You're not even here anymore, you're over there somewhere. So when we go here, you're going to hear descriptions like that. She was out of her mind, beside herself, overcome with that emotion. Now that's not just the theory I'm spouting off, this has been proven. They've taken trauma survivors and they started with people that had PTSD, and they started with war vets. And they did PET scans on them. And the PET scan shows the activity of your brain. So it shows the chemicals and the activity of your brain. And they got the Vietnam vets actually, they got them in a state of hyperarousal PTSD symptoms. And what they noticed when they got them all stirred up with those symptoms, they noticed that their prefrontal cortex turns off. So it's not just the theory that your brain shuts down, you're actually going into the fight or flight response. If you start saying to yourself, oh my God, mayday, mayday, this is a bad thing, your adrenal glands start pumping and you're going to get adrenaline and cortisol, you're going to get flooded with stress hormones. If you get flooded with stress hormones, there's a very interesting cascade of events that take place in your body and your biology. Your digestive system temporarily turns off. Your immune system temporarily turns off, your reproductive system temporarily turns off, and your prefrontal cortex temporarily turns off. Why do you think God made us so that if there's a life-threatening situation or you perceive a life-threatening situation, that our digestive, immune, reproductive, and prefrontal cortex would turn off?
So you don't have to worry about taking care of those.
Do what?
So you don't have to worry about taking care of those because you're in.
Yes, you don't have to worry about taking care of those. You're in straight fight or flight. What else? Survival. How? How does it help us survive? By turning off certain systems.
Sit and say, okay, well, if I don't turn around and run, this bear might eat me, but he might walk off. You're not sitting there
Processing it out. You're
just going.
That's right.
Saving the energy for your vital organs.
Do what?
Saving the energy to run your vital organs.
Saving the energy for your vital organs and your vital limbs that are going to be needed to take off, right? So you hear about these women who are 80 pounds and they can lift a car off of their kid when there's an accident, and you think, what the heck? Well, what caused that? And I said, well, adrenaline caused that. Well, okay, what's the adrenaline do? She didn't bust out of her clothes like Incredible Hulk. She didn't grow more muscles. What the heck does adrenaline actually do? The adrenaline signals her body, shut down everything we don't need in this moment to conserve energy. In my old house, I could not run the dishwasher, the washer, the dryer, and my blow dryer at the same time. Why?
Too much.
Yeah, it's more than the house had. It would blow a breaker. I'd have to, flip a switch in the breaker. So I had to learn. My house didn't have that much it could pull from for all those different things. So the reason that woman that's 80 pounds that couldn't lift 50 can lift hundreds off of her child is because she went into fight or flight, her adrenal glands started pumping, she was flooded with stress hormones, which is the cortisol, adrenaline, just to name a few. She got flooded with stress hormones, and those stress hormones told her body, shut down everything we don't need. Prefrontal cortex, we don't need to think about stuff. Prefrontal cortex, we don't need to digest the hamburger. We don't need to use our reproductive system, well, duh. We don't need to have our immune system fighting the cold. I gotta save my kid. So if you conserve all this energy, now all of a sudden this body has energy it can tap into that it would not normally have on reserve, and it can lift that car. So that's how that happens. That's what that does. Okay, so that's great to have in a moment of a crisis. But if someone has a trauma history, you just go up and tap them on the shoulder, what do? They jump. They have this hyperstartle response. So what happens is there's like a part of their mind that's still on hyper alert all of the time. And that takes energy. And that requires part of your brain. And so here's this hyper alert self over here all the time, ready to go anytime. Now, if you have a car and you sit in that car and you turn the car keys on, off, on, off, on, off, on, off, are you eventually going to tear up your starter? Yeah, it'll tear it up. If you constantly are wearing and abusing something like that and it doesn't have time to recover, you're going to tear it up. So does it surprise you that they've also found that people that have a lot of unsuppressed emotion, or they have childhood trauma, or they've had aversive childhood experiences, or they have a lot of pain they've never dealt with, whatever words fit there for you, does it surprise you that when they look at that population, they have a higher incidence of irritable bowel syndrome because their digestive system has shut down. Spastic colon, colitis, all these different things, the GI stuff, if there's suppressed emotions and you haven't dealt with them, your body, remember the body keeps the score, they have a higher number of people with digestive issues. They have a higher number of people that get sick easier. They have a higher number of people that struggle with infertility. How many of y'all have known people that tried to have a baby and couldn't get pregnant, and then as soon as they signed up for adoption, were able to get pregnant? I know her. I know one of those real well. Absolutely. So the stress in your body, if you get too worked up about something, you're going to trigger your natural fight or flight response that you cannot necessarily control. So then, when people come in, and if they make mountains out of molehills, and they do this a lot, and they shut off their mind up here, so they dissociate. This way you dissociate from your mind. This way you dissociate from your what? Your body. This way you lose connection with your mind. This way you lose connection with your body. Whichever direction you go that you lose connection with. If I have anger and I don't know how to deal with it, and I go to rage and I disconnect from my mind and my body, is it easier or harder to act out? If your mind's gone, is it easier or harder to do something you know you shouldn't do? It's easier. So when people come to me and they say, I can't control my eating disorders, I can't control my alcohol abuse, I can't control my dissociative disorders. If people come to me and they say, I cannot control these behaviors, I don't start wrestling with them in this area. Now, we've built a facility where we don't have things they can hurt themselves with. They don't have drugs and alcohol available. We've built a facility to take these things out. But when people come to me and they say, I can't control it, and their depression or whatever it is, this isn't the point that I'm going to wrestle with them. What I explain to them is, you know what? When you're here, you don't have any control. You're right. When you're over here, when you're here, you don't have any control. When you're here, you don't have any control. When you're here, you don't have any control. I can kind of see how maybe I could, but I still don't have it. When you're here, you have a little bit more control, but you still can't do it. When you're here, you have more control. When you're here, you have control. When you're here, you have total control. So in the middle, where mind and body are together working side by side, this is why we don't want people to not have their mind and their bodies working together. When you're in that middle and mind and body are side by side working there, you can control your behaviors. But if you start ramping it up and getting yourself all worked up, you're going to accidentally trigger your own fight or flight response. You're going to trigger your adrenal glands to produce the adrenaline and all the stress hormones. Your digestive, immune, reproductive, and prefrontal cortex is going to turn off. This is where impulse disorders live. You've got to lose your mind. Nobody is coming to our offices or coming to the programs and saying, I don't know why I'm here. I mean, you might every once in a while, and they'll say, well, my wife made me come, or my husband made me come. But for the most part, people know why they need our services. They know I can't stop drinking. They know I want to harm myself. I don't have good self-esteem. I struggle with depression. I can't control my anger. I'm overwhelmed with anxiety. They know what the problem is when they come see us. So why can't we just say, you seem like a very intelligent person. You are a rocket scientist, actually. Drinking is destroying your life, right? Yeah, okay. Got an idea. Stop drinking. Try that one on for size. Just don't drink anymore. People are very intelligent folks. Why would people continue to engage in behaviors that they know are destroying their life if there's not a disconnect between the two? So what happens is we actually become addicted to the dissociation that getting caught up in our emotions. If we can ramp our feelings up and lose our right mind, because we don't know what else to do. Here comes the anger. We don't know what else to do. If we go to this extreme place, ramp it up, and our mind turns off, then we can go do what we shouldn't do and not have to feel guilty for it because I couldn't help it or I was out of my right mind. So it's a way to absolve the person from a sense of responsibility, because when they say they can't help it over here, they really can't, because their mind is gone. And so treatment doesn't happen here. Treatment happens teaching people how to get back over here. That's where treatment's going to happen, is teaching people how to be in this healthy range with their feelings. So let's give an example of what that looks like. Right here in the middle, there was a man that came to my office. He had lost his marriage, his job, his driver's license, his career, and custody of his daughter, his little girl. He had to have supervised visitation if he ever wanted to see her. And he knows that he knows drinking's destroying his life. So he knows it. He knows what the problem is. His brain gets it. Why can't he stop it? So he's in therapy and he's working. And we're starting to learn how to get in touch. And I have to, when the man comes in, when someone's drinking, that doesn't tell me anything. It just tells me he's using something to avoid pain. So I've got to kind of look at, where's he energetically off balance? So I have to start looking at, does this man seem to get more angry when he's with me, or does he seem to get more sad? Where does he lean? Where does he seem to go more into than the other? Is he more angry? Is he more sad? So as I get to know him, I'll start to see patterns. And if he starts going into his sadness a lot, where do you think I'm going to start encouraging him to get more experience? In his anger. If he tends to get a little bit fired up too soon, I'm going to encourage him to get practice getting comfortable with his feelings of sadness, vulnerability, hurt. So we're practicing that. Just the virtue of his addictive behavior, or whatever the symptom is, that doesn't necessarily tell me where the problem lies or what the feeling is that he's struggling with, unless it's major depression. It makes it a little easier, but for the most part, I don't know where they're energetically off balance. I just know they are energetically off balance, or they wouldn't be using something. I've got to figure out, where is this person struggling? Are they leaning more into this side or into this side? Or some people lean over into the numb, disconnected side a lot of the times. So let's go back to the gentleman who's lost all these things because of his alcoholism, and he knows alcohol's destroying his life. So he goes for supervised visitation to see his little girl. And he's sad just going in there. He's sad about just going in to see her. It's a sad thing. And he's right here. His mind and body are there. He makes himself go to the supervised visitation. The social worker brings the little girl out. He's happy to see her. He's also sad about what all she's going through. They're both there. And the little girl looks at him and she says, and bursts into tears and says, I don't want to see my daddy. My mommy cries herself to sleep every night. I'm so mad at my daddy. How could he do this to us? I don't want to see him. Please don't make me see him. For the man that has been drinking away his pain, his sadness for 15 years, when she did that, did he get triggered? Did he have a feeling? Yeah, he felt sadness. He felt a lot of sad. He might have felt some guilt, but he felt a lot of sad. So here he is in this room, in his body, in his head, having to be aware of what his behaviors have done, having to accept it and own it and be grounded, and feel the sadness and feel the guilt and have all these feelings come up. If he can't manage that, which he probably isn't going to be able to manage it because he hasn't done this for 15 years without drinking, if he can't manage it, what he will wind up doing is he'll say something like this, and he goes up in his head and he says something like this. He'll say, she's right, she deserves better, I'm just making her life worse. Just being here is causing her pain. If he starts saying all that stuff to himself, will that walk him over here? You bet. Or the guilt into this. If he starts walking over into this mind-numbing gray area right here, is he more likely or less likely to drink? More likely. If he makes mountains out of molehills, he will lose his mind. But you know what? There's value to that. Because if he pulls away and splits himself, mind from body, and gets lost in this emotional state by triggering his fight or flight response, and his prefrontal cortex is gone, and now he's just in this real depressive, reactive position of this hopeless and depression and all this stuff, the hurt and pain, if he goes over here, then he can act out and he won't have to feel guilty for doing something he knows he shouldn't be doing. We get addicted to the dissociation. We get addicted to disconnecting because this hurts more than this. I'll show you again. This hurts more. It's more difficult to manage. There's more grief there. Being mind-body connected, mind and body both there, hurts more than separating it apart. This is easier. And matter of fact, if I can't manage that one, if I can't manage this extreme, then I'll go into this behavior and that'll manage it for me. Now, when we separate that apart, are those now polarized emotions? Polarized means extremes. Are those extreme emotions? Yes. If we can keep our head there, We can keep ourselves feeling them in that middle range. That's why I need people's logic. If you pull that apart and you trigger your fight or flight response and you start saying all this garbage, get yourself into this place, you will lose your mind. Your mind's going to be gone. Believe it or not, that's less painful. This is more painful. Can you think of any other reason why this is more painful than this? This requires a sense of responsibility, accountability, being present, being grounded. There's responsibility to self. This requires, my feelings are pure emotions or pure energy. They're letting me know something about my environment. This means I've got to do something. There's a behavior going to be associated with that because it's a signal. My feelings are signals. What am I going to do about that feeling? And if you don't have any self-esteem or self-confidence, you don't feel like you can do anything about that feeling. So it's easier to do this. Get all worked up over here, act out, and then go drink. You won't drink excessively from this place. When mind and body are together, you won't do it. Because you know better and you're in control of yourself. Now, it doesn't have to be totally linear like this. There can be cross-pollination going on. You can have someone that is very, very sad, something happens, and they don't know how to deal with their sadness. So instead they flip it into anger, which is what we've been talking about. And that's one step removed from that sadness, right? But then you can go, well, that's not enough, it still hurts. Go over here to rage. That's 2 steps removed from the original sadness. Then go over here and pop into this. Hit somebody, act out aggressively. That's 3 steps removed away from the original sadness, and more than likely the person you hit isn't going to say, oh, tell me what's hurting. I can see the sadness. It's a great smokescreen. All these behaviors are great smokescreens. So we get addicted to losing our mind to get over here and act out. This is the root of all addictions. There's not an addiction out there. Nobody will use from this place. Now, sometimes people will use, let's go this way, where they're all in their mind and they're disconnected from their body. And they all live up here. This over here is where psychiatric diagnoses tend to pile up. And going over, if you live in the numbed out, disconnected part, if that's where you seem to go the majority of your emotional life, you're going to probably have some medical diagnoses that come up with it. So these are the people that will say to me, Melissa, I'm just not an angry person. I just don't really ever get angry about anything. Good Christian people don't get angry. I know I have 6 bleeding ulcers. What does that have to do with anything? So your head can convince yourself that there's no feeling there, but your body will rat you out. Your body will tell you something else. It'll let us know. So a lot of medical diagnoses are going to be over here where people are very numb and shut down. For people that have a lot of suppressed or a lot of painful experiences growing up, they tend to go back and forth. They have a feeling and they stuff it. They have a feeling and they stuff it. They have a feeling and they stuff it. Stuff, and then boom, they blow out over here. So a lot of times people so here's how I word it. I will say to people, where do you spend the majority of your emotional life? Is the majority of your emotional life in column 1, column 2, or column 3? And most people will, probably 3/4 of the folks will say, they're over here. This is where you see a lot of the acting out. There'll be a small percentage over here. And some people will say, because this one isn't as common. This is more, stereotypically speaking, which I know is not the right thing to do, but just to kind of give you a general idea, this tends to be more men over here. More men a lot of times are over there because in this culture you're not supposed to have any feelings. So they tend to be more up in their head and they put all of their self-worth in their logic. This tends to be more women. But you can have men over here and you can have women over there. So some people say, well, I can do these feelings. I say, well, I know you can do some of them. Nobody is off the charts all the time. I know you can do some of those. But if you lived the majority of your emotional life in this column, you wouldn't be in this building. You wouldn't be here. Because you wouldn't be falling into patterns of addictive cycles to try to suppress the pain. Because your pain is so big, you have to do this. So if they're either here majority of the time, or they're here majority of the time, or they're bouncing back and forth between those two. That last category when I say, or you bounce back and forth, you stuff it, and you blow up, that will get everybody. Everybody's like, whoever doesn't have their hand up at that point will say yes. So a lot of times, because of that, you'll have people that have a lot of psychiatric diagnoses that also have a lot of medical diagnoses also. They're just kind of, if this is struggling and you're in the fight or flight response and this is struggling, now this is still a fight or flight response also. There's fight, flight, freeze, and total submission. Those are 4 mammalian responses. Those are 4 mammalian responses to life-threatening situations. If you're someone that's got a lot of suppressed emotion or you had a lot of painful things happen, like I said, tapping the shoulder, they jump out of their skin. So they're always on that hypervigilant, life-threatening is very, very close. So they can go there very quickly. The goal is to get mind and body together. If someone's over here, always there's a polarized emotion before they get here. You have to go through you have to go through this mind-numbing place and go into this extreme place where your mind turns off, mind-numbing, gray area. You kind of start to go away. You dissociate from your mind. Your cortisol levels take off. You won't have a psychiatric diagnosis if you aren't polarized in a feeling before that. You won't have them. There's got to be a polarized feeling. There's a strong emotion. That's where I start saying, let's find where that person is energetically off balance. Let's find out if he's leaning into his rage, if he's leaning more into his sadness, if he's leaning more into helplessness, if he's leaning more into numbness. Find out where that person is kind of emotionally off center or not emotionally balanced. Because you won't have these, people won't do these unless they do this first. It's real important that everybody understands that. Because the place of intervention is not right here. I'll see these psychiatrists fight with these eating disorder clients, and they'll say, the client says, you can't do that. I'm in control. And they're like, you're not in control. You weigh 80 pounds. You're not in control? No, doctor, I am in control. No, you're not. I sent you to the ER last week because your kidneys are shutting down on you. You are not in control. Yes, I am. No, you're not. And they fight with them about the context. They fight with them at the veneer level. To fight with people over their drug abuse, the alcohol abuse, their sexually acting out, their eating disorders, to fight with them at that level is ridiculous. It does nothing. You're focused on the context. Get a little deeper. Is that lady that tells that doctor she's in control when she's 80 pounds, is she in control?
She's in control of what she's not doing.
She's in control of her feelings. She sure is. She's in control of her feelings. So for him to be telling her she's not in control, she knows darn well she is. Because when she does those things to her body, that painful feeling goes away. The art of and the practice of therapy is helping people recognize this. Because they want to say, I drink for no reason. Or I have this happening out of the blue. Or there's no connection to my dissociation. There always is. Always, always, always. And the treatment objective is to feel my feelings and stay safe, which means they're doing these behaviors to shove the feelings down. So let's go back to, I'll give an example. Well, let me ask this first. Can you be enraged and terrified at the same time? You want to think you can. What you actually see is someone can go from rage to terror to depression. They can bounce from, I can see someone curled up in the corner in a total helpless place and then come out in a rage, but you can't feel those at the exact same moment. It's incompatible. You cannot feel. These are all or nothing, man. This is all there is. When you're in it, you're in it. You cannot feel them at the same time, but you can sure go from one to the next, to the next, to the next, but not at the same time. Can you be angry, sad, hurt, vulnerable, happy, guilty, have fear? Can you feel those at the same time? Well, yeah, because they're in moderation. You can actually feel a mixture of those. Remember I talked about conflict is where a healthier person lives, is in a conflict where you can experience more than one feeling. Here's the best example that I can give. It's a personal example. When I was 24 years old, my mother died of breast cancer. And it was about a 6-year experience for her. It was terrible. It was terrible to watch. It was terrible for us. It was terrible for her. It was traumatic. It was traumatic for me just to watch. It took 10 years to stop having nightmares about it. But it was a very traumatic experience. I was in graduate school. I was learning all about feelings. I knew my feelings were okay. I knew all feelings were fine. It was a long, drawn-out process. She was in a lot of pain. And I remember when she finally died, I could manage. I had all these different feelings come up, and I could manage all those. I could deal with all those. I understood that. I understood the stages of grief. I got all that. I was a graduate student. But there was this feeling that kept coming into my little world, my space. It kept coming in, and I kept pushing it away. And at the time, I didn't even realize I was doing it. It's not till later I look back, I'm like, that's what was going on. And this feeling came up, and I kept pushing it away, and it was very uncomfortable, and I didn't want to think about it, and I just kept pushing it away, and it kept trying to intrude in, and it was bothering me. And I finally, thank God for home hospice, because that wonderful nurse, she was talking to me, and I don't even remember how the conversation got going. But I remember she said, let's use a different word. She said, the feeling that you're feeling, can anybody guess? That was there. I could feel that one. It felt like happy.
You were happy because she wasn't in pain anymore.
Yes.
It wasn't right to feel that way.
Yes. So I felt happy, and that feeling of happiness kept kind of wiggling in, and I was like, oh, and it was terrible. And she reframed it for me. And you know what word she gave? Relieved. She said, you feel relieved. This is relief. It's not happy, ha-ha, I'm having a great time. But I didn't understand what to do with that feeling, because it didn't feel right to have with everything I'd been through. Once she labeled it relief, it's like, oh, that was relief just to hear that, because it helped me identify what that feeling was. But it felt so similar to happiness, I couldn't quite make it work. If she hadn't done that for me, I know what I would have done. If I couldn't have figured out how to make that go away, I would have started feeling guilty about having that, and then I would have gone to shame, and then who knows, I could have gone into depression, I could have gone into anything. This is where this is where grief lives. Grief is a compound feeling. There's more than one emotion there. And when people say, well, when have you ever finished grieving? And when we know the DABDA, depression, anger, bargaining, denial, those are the stages of grief, right? We know those. Those are polarized places. And they say people go from depression, and then you hear about some people who are stuck in the depression for 20 years. I'm like, oh God, what's up about that stage? Nobody can move through it. Grief is, you hope people can move through them, because when people say, when are you through doing your grief work? I would say, when you can feel all of those. And sometimes when the pain is so great, you can't do them all at once. You kind of have to break it apart and do little sections at a time. So you do your anger for a little bit, then you do your bargaining for a little bit, then you do your depression for a little bit. You move through it. But I would say a healthy place for grief, when you've resolved it, if you could say you resolved grief, is when you actually have integrated it all. There are some days that I'm angry that my mom's not here. There's things I want to tell her about. There are some days I'm sad that she's not here, or I feel lonely for my mom. And then there are some days, and people don't like to even admit it, I don't even think about her. When you can get more comfortable with all these different feelings, and they're all allowed to be there at once, that's when your grief is resolved. Is it gone? It's not gone, but it's no longer polarized. I don't have to go to these little pockets, these little extreme places to experience my feelings over here anymore. I've learned how to tolerate them all. I have this pool now, and I can kind of lean into these different feelings at different times, depending on what's going on in my life. We want to be in moderation right here. Does that make sense? Are there any questions? Y'all are making this way too easy. No questions? So for people that come over here, a lot of times, trying to talk to them about feelings isn't very easy, because they're all numbed out and disconnected anyway, and they don't talk about their feelings, and those are usually the ones that their wives made them come, because they don't have any feelings and they're more robotic. Quite often what I'll do is I'll start asking questions about medical diagnoses. I say, you know what? We did such a thorough psychosocial, but I never really asked you, do you have any medical symptoms? And he'll say, well, you know, that's so weird. You should ask me that. I have had migraines since I was 7 years old. I've been to every neurologist, I've been to every doctor, I've had every kind of test, every kind of scan, every kind of blood work. They've done everything to try to figure out what is wrong and why I have these migraines, and nobody can ever figure out why they're there. So what I will ask that person to do, and this always makes them mad at first, I say, well, that's interesting. We've got to figure out why your head is hurting you. What is that about? There's a reason your head keeps hurting you. Now, I know they're pushing all of their feeling up into their headaches. Or some people push it all into stomach aches, or shoulder aches, or their back hurts, or high blood pressure. They're holding it in. People can push it in their body. So I said, I want you to do something. I want you to think of your head as a separate person. And I want you to ask your head why it's hurting you. And I want you to do a writing assignment for me. I want you to, and I said, I want you to write down as if your head is talking to you. We're going to think of your head as someone separate. Because it already is. Because mind and body, this person's already dissociated. So I'm going to say, let your head write you a letter. And he'll like, seriously? Like, let my head write me a letter? I'm like, yeah. Well, what's it supposed to say? Dear Bill? I'm like, well, is that your name? Yeah. So he says, okay, so my head's supposed to write me a letter. I said, yes. He said, okay. I said, it can start out, Dear Bill. And I want your head to tell you what it wants, needs, thinks, and feels. I want your head to tell you what it wants, needs, thinks, and feels. It's okay, lady, let me get this right. You want my head to write me a letter and tell me what it wants, needs, thinks, and feels. I said, yes. And he said, well, that's about the dumbest thing I've ever heard. I said, well, let's try something different because your way's not working, obviously, or you wouldn't be here. So let's try something that may sound dumb to you, but let's try something different. I said, now, are you right-handed or left-handed? He said, I'm right-handed. I said, okay, I want you to write the letter with your left hand. I'm like, seriously? What is that about? Why? And so I tell people, when we can write with our dominant hand, we can filter stuff through it. We don't even realize it because we have so much control. Just like the man having to throw the clay underhand like that, where he lost control and all that energy came out and he couldn't control it, and all that sadness came. When you write with your non-dominant hand, you don't have the same amount of control and stuff just will come out. So, and you get a lot of resistance if it's a CPA or an attorney or a lot of people that live up in their heads. And you have to kind of work on them and say, hey, just humor me. I need you to do this assignment. Give your head permission to write your letter. And that same guy came into me and he said the next day, and I said, did you do your assignment? And he goes, yes. I said, and? He goes, oh my God, my head hates me. It hates me. And so all this anger, and I said, really? He said, oh yeah, listen what my head said. My head told me that it's sick and tired of me dumping everything in it. It's sick and tired of having to hold everything in for me. It's sick and tired. And he just started naming off these things from the past that were hurtful that he never dealt with. And it's amazing when you can get people, am I going kind of along with the ego states therapy? Because I told y'all earlier, all of my fundamental practice, internship, years of experience was from treating people that had multiple personality disorder. There's this personality that's angry and her name Betty. There's this personality that's happy and her name's Susie. There's this personality that's sad and her name's Jill. Since that was my basic training that I went through in this field, I've learned how that's applicable for every diagnosis. So I'm going to ask somebody, where's the part of you that drinks? Because I know where the part of you that doesn't drink. There's the part of you that's in recovery that wants to change your life, but there's still this part of you that wants to drink all the time. We need to get you connected with the part that wants to drink all the time. They're two different parts. So you give them, am I actually kind of colluding with an internal defense mechanism of separateness? I am, but my intention is to bring them all together. So while I am focusing on separating and breaking that person up, because it's just, if you don't, it's just all up here, it's all this nebulous. I mean, generalized anxiety, who can do anything with that? So you want to make it more specific. And I'm going to say, the part of you, I want you to let the part of you that has the anxiety write you a letter. I want you to have the part of you that has to drink, the addict in you, I want him to write you a letter. I want you to write a letter to the addict. I want you in psychodrama to role play the addict talking to you and what you're going to say back to the addict next time. because they're different compartments of mind. They're different ego states. I went from all about DID and multiple personality disorder, then I heard about ego state therapy, where it's all about the different ego states that different people have. And everybody has an inner child, whether you believe it or not. Everybody in California knows they do. Texas, not so much. Everybody has an inner child. Everybody has a teenager that can get angry and rebellious to protect this. There's a wounded child if you've had a lot of trauma. Everybody has more of a female side. Everybody has can have male tendencies too. There are female, there's masculine, feminine. Kind of the archetypes that you've studied in school. Everybody has a parent, an internal critic. Everybody has different ego states. And so start by breaking up the client's ego states and looking for the places that they've kind of identified and they don't have as much control over. Because if they had control over it, they'd be integrated. And if they were integrated, they'd be functioning from this place right here. So we already know if they're over here or over here, or over here or over here, there's fracturing that has taken place. There's ego states that are separate from one another, or they wouldn't have these symptoms. So help them find that. Sometimes it's broken down by feelings. Sometimes it's the part that's angry. Sometimes it's the ego state that's sad. Sometimes it's the inner child. Sometimes it's the wounded child. Sometimes it's the traumatized child. Sometimes it's the rebellious teenager. Start listening to the language and start looking at the behaviors and find the ego states that the person is in conflict with. Because the bottom line is, when you're talking about people that have multiple personality disorder, there's a host that's up front and there's different alters back here that can come forward. And for someone who's truly DID, these parts can come forward and the host steps back. And then this person acts and does all these things. And then when she comes back, she has no memory of what just took place. That's true DID. But for a lot of people, they have these different parts of self stacked all around here. And they just kind of rotate who's there. But the host, so to speak, doesn't go away. So when you talk about ego states, it's just different parts of self. And they're in conflict with one another. And the person is trying to suppress the ego states they don't like. Colin in his book talks about making friends with Satan. So some of the parts of yourself that you don't like, that you want to push down, you've got to actually embrace those parts and get to know those parts and get to learn about those parts and start forming an alliance with those parts so you're no longer at war within yourself, and the host just gets stronger and stronger, because the more parts that can come together and work together, the more centralized, core, central connectedness that the person has, and that's a better frame of reference where you're going to be a lot more in control than all these little broken fragments all over the place. Does that make sense? Does anybody have any questions?
Do you just have to repeatedly go through these exercises? And because it sounds easy when you say it.
Right.
But when you have clients, is it repeatedly going through this?
Her question is, do you have to repeatedly go through this? She says you're making this sound easy. And this is the easy part, explaining it, right? So practicing it. And the hard thing is, for me, if I'm practicing something that I don't totally feel comfortable with yet, that can come across to the client. So if you're not totally sure of something working, guess what? It's not going to work. So much of it has to do with, this is where psychology, it's not the placebo effect, it's just the unconditional positive regard. If you can have that connectivity and you have faith in this. So when someone says to me, I don't have self-worth, and I say to them, no, I think everybody has self-worth. Or I say, everybody has self-worth. Everybody. You are born with self-worth. Which one's more believable? So a lot of this is you owning what you're teaching and you believing in what you know to be your truth and having a personal philosophy that you can talk with your clients about, because it's that owning of it that gives them permission to own it, because you're doing it for them. You're teaching them how. And a lot of people will say, it sounds like the therapy y'all do a lot of times is almost just like reparenting. I said, well, that's true, except for some people there's no they didn't have it to begin with. So it is parenting. And when you tell somebody, we have a young man now, when you look at him and you say, I am so proud of you doing this. You are taking steps now that lots of other people 20 years your senior never do. I'm so proud of you. I can see the real you in there, despite all these crazy behaviors and all this stuff that's out of control. I see the good human being. I see your spirit. I see you. If you can hold that with a person and be present with a person and almost own that for them, you're kind of working in tandem with the client, then they'll be able to start to own that too. But yes, it takes practice and practice and practice and sitting in with people and watching how it's done and just pushing yourself a little bit more and then reading the books, and you start getting more and more comfortable with it.
But does your client ever, I mean, the first time you walk them through this, is it like, oh, okay.
Yes, when I teach this in the education groups, most people are like, holy cow, this has never all made sense like this to me. No one ever helped me realize that because they'll say, I had horrible OCD when I was like 9 and 10, I remember that, and then when I was a teenager, I acted out sexually, and then I was struggling with drinking when I was in college, and then I started having gambling in my 30s, and now here I am with this, and so no one's ever explained to me how those are all connected. I never understood how this all worked. I just went to this facility for this and that facility for that and this special therapy for this and that special therapy for that. Nobody ever explained how this all fits together. So most people are very relieved because this gives them a sense, a lot of times just understanding it gives you a sense of power, just understanding. So you don't just feel like you're just kind of lost in this world of all this psychobabble and all these different theories and all these different ideas. If you can get and that's where the best programs I've ever worked in, and that's why I think the trauma programs have done so well over the years, is there's a core foundation in this model. And if everybody gets it, now I'm going to put it through the Melissa blender, and Dusty's going to put it through the Dusty blender, and Kim's going to put it through the Kim blender, and everybody's going to say it in different ways. But if this is the foundation we're working from, it's so cohesive, people learn this so much quicker because they're not hearing different theories all over the place while they're in one building. So to have a core theory that we all work from, which is this, I think is the most important thing for treatment to be effective. And that's not just what I think, that's what I've seen. Because I've gone into these facilities where they've asked me to do some consultation, and they're like, well, we hired her because she's good at a process group, and we hired her because she does this, and we hired her. And that's not bad, you can put it all together, but if you want to take it up a whole lot more and have all those people that have these really good skills, and then have them have a centralized philosophy that they're working from, and then have them do what they're good at, where their passion is, we're all on the same page. And that gives the client a common language to use. I do family sessions, and I go over this with the spouse and the families, and they're like, holy cow, this all makes sense to me. And it gives them a common language when they're talking, because most people don't even know how to describe their feelings. I mean, the majority of the world out there, this is where I'm glad you're sitting down, most of the world out there is not that healthy. We have more addiction and more people struggling and messed up and lost in all kinds of chaos out there now than we ever have. There's a continuation of this, which is where we talk about, because usually, and we don't have time to go into it today, but usually people ask, how do you help people get back here? What do you do to get them back here? You're right, my clients go over this way, or they start going over this way. What do you do to bring them back here? And that's another long discussion we'll go into, but just understanding how this works, how mind and body comes together. And people say all the time, well, we do mind-body work. Okay, well, what's that mean? Just like we do feeling work. Well, what's that mean? Tell me exactly what that looks like. I don't want to just go hear about theory. I want to hear how that coming out of your mouth, what does that look like? What would you say to a person? How do you couch that? And so this at least gives you a template for how to use this. Do you understand how this is applicable to any diagnosis? Any diagnosis in the DSM? Any of them, absolutely.